咁嗱，你要 share screen。Good morning, ladies and gentlemen. This is Gary Z. I'm a representative from the International Academy of Pathology, Hong Kong Division. A warm welcome to all of you to the session that is conjointly organized by the IAP Division, the IAP Hong Kong Division, as well as the Assembly of the Asia Pacific IAP. This is the WHO update series, and since 2 years ago, we have already organized 3 other sessions in this series. Today's session is the 4th series, and we started this 2 years ago. These series updates have taken place or been organized by Singaporean Division and the Hong Kong Division. So today we are going to concentrate on head and neck pathology. We are very honored today to have 3 eminent speakers. Practically, they do not need further introduction, and they are heavily involved in the new edition of the head and neck WHO tumor update. They are all editors in that particular series. Our speakers include Dr. Justin Bishop from the University of Texas Southwestern Medical Center, Dr. Lester Thompson, head and neck pathology consultations currently in California, and Dr. Bruce Wennick, who is now in Moffitt Cancer Center in Florida. This morning, the session will cover a wide range of topics in the head and neck pathology, particularly the updates that are going to take place in the 5th edition of the WHO book. So I hope you would enjoy this morning's program. And without further ado, we will start with the lectures. Thank you very much.
Hello, it's a great pleasure for me to be able to present an update from the new World Health Organization Classification of Tumors 5th edition, and specifically as it relates to the head and neck. Unfortunately, I do have some disclosures from several royalties, and also in this particular case, being a standing editorial board member of the World Health Organization Tumor Classification, as well as an expert member for this particular edition. If you don't know what the names of things are, then the knowledge of them is lost too. This was a quote from one of the original books by Carl Linnaeus, as he was coming up with a classification system for botany. And so if you look at that where we are today, giving the correct names to cancers that we are ready to make a mission to defeat them. So with that in mind, let's talk about the strategy first of all. So since 1956, the World Health Organization has been responsible for the classification of tumors in all organs and systems. And specifically, the Blue Books provide an evidence-based classification for tumor types to enable diagnosis and research worldwide. Of course, this underpins patient treatment as well as research into all aspects of cancer, both causation, prevention, therapy, and even education. So the WHO books are not just for pathologists. They offer a whole variety of different groups of people that are involved in cancer and tumor classification. There have been several updates and things that are different now with the 5th edition, specifically around governance, quality and standards, and of course, production. So let's just talk about the better overall governance. First of all, the editorial board was established in 2017 with both standing members as well as expert members who would lead the classification and decide on what the entries and so forth would be based on evidence. Informed bibliometrics were used to select the various editors and authors, removing selection bias from this process. And in fact, there have been more than 2,500 authors involved in the overall 5th edition. There have been several other organizations involved in the classification system as well, from coding and staging to genetics and implementation, among several others. So when it comes to the quality and standards, there has never been one specific overarching classification managed in a database using Linnaean principles. And so that is what has been performed with the 5th edition, greatly improving harmonization across all of the various anatomic sites. So for instance, things like neuroendocrine neoplasms have been uniformly addressed throughout all of the body systems. Same thing with hematolymphoid, soft tissue, and even familial syndromes, metastatic disease, melanoma, etc. So it allows for the same terminology and the same diagnostic criteria to be utilized no matter what it may be. There has also been a significant improvement in the image quality, linking the references to PubMed unique IDs, standardizing the various approaches with statistics, and of course, covering global epidemiology as well as mandating SI units, specifically as it relates to mitoses with per 2 square millimeters. There has also been a major focus on multidisciplinary approach. So much of what we do in daily practice involves the working with multiple different groups in order to get the best management for the patient. And so those same individuals were used to come up with the classification system. Now, you may say, what about the production side? Well, they are now going to be on a every 5-year publication basis from the time that the first volume appeared. And this is going to greatly speed up the process versus what it may have been in past, where there were up to 12, even 15 years between the various editions. Furthermore, website access is going to allow for easier access to references and digitized whole slide images, and of course, notes that would be able to be made by individuals in that setting as well. So overall, I think that there has been a great improvement in just the underlying mechanistic approach to what we do with the World Health Organization books. So as you know, it's managed by the WHO Tumor Editorial Board. This is chaired by an individual from the IROC system with multiple standing members. Those standing members are nominated by various societies, specifically around cancer diagnostics globally. They serve for a 3-year term, which may be subject to 1 renewal, but absolutely no more than that. So a 6-year term limit, if you will. The expert members have been selected also based on bibliometric knowledge of the field, using consultation as well as input from those standing members previously described. They serve on the board for the duration of the book in which they're appointed. They can serve on no more than 2 books simultaneously and also no more than 2 editions. So the idea behind this is to allow multiple different individuals over time to be able to be involved in the tumor classification system. Of course, all of the members have equal status, so everyone can say exactly what they feel. And even though Zoom allowed for an instantaneous muting if they became a rowdy group, it still allowed for everyone to have an equal standing in these meetings. So the authors were selected the same way, using these bibliometric searches and having a substantive publication in the field during the previous 5 years, taking various geography and expertise into consideration, and of course having English as a written language for submission as the first or responsible author role. There were lots of different people involved in this as well. While pathology certainly is perhaps overrepresented, individuals from cytology, oncology, surgery, radiology, etc., were all included in order to be able to have a much more multidisciplinary approach to this. So specifically for the entire 5th edition, there are 31 standing members. So this tells you that it's a very broad group of individuals, 14 countries and all the disciplines represented, with almost 200 expert editors for each of the various sub-books or anatomic site distribution. More than 2,500 authors from 30 countries are represented in this. So now let me just narrow it to the collaborations. I think this is a very significant thing as well, with the collaborations working with a variety of other international organizations. So let's just take ICD-9 and ICD-10, ICD-0 specifically as the groupings. These are, as you know, utilized globally for its standardization of topography and morphology, as well as behavior taken into consideration. There has also been working with the UICC and HACC for staging, while the International Collaboration on Cancer Reporting, or ICCR, has been involved in the standard general reporting of these lesions. And then, of course, multiple different academies and organizations or societies from the global community are used for implementation and recommendations on what is going on with the work. So here is just an example of such a thing. This is taken from the salivary glands as a histopathology reporting guide from the ICCR, and these are freely available from their website and allow for everyone across the globe to utilize the exact same information in their reporting system so that there can be a comparison meaningfully between not only different organizations, but also different geographic areas. So of course, the ultimate goal for all of this is to be able to improve patient care, cancer prevention, and producing a definitive evidence-based classification of all tumor types that will enable diagnosis and research worldwide. So as you know, with these various books, 6 have already come out. There are 3 presently in beta version on the World Health Organization Tumor Online System. If you go to tumorclassification.iarc.who.int, you'd be able to see this entire group. And here is an example of them now. You will notice that the head and neck one here at the top is the most recent addition to this, with a little small beta written there, as this is still a work in progress. Part of this is just to say that if one does go there and there's a typographical error or a syntax error, or heaven forbid, an error of omission or commission, they are still able to be corrected prior to the print version of the book being released. So if you think back to how the overall meetings have gone in the past, this was an example of all of the members of the 2003 or 3rd edition classification in Lyon, France back in July. This is the one that occurred in January of 2016. As you'll tell, we're indoors because this is, of course, January, and who wants to be outdoors in Lyon in January? And alas, this last year, 2021, Zoom took over the IROC system as well, and so the WHO editorial board meetings were held in this particular disposition. Nonetheless, we were quite successful in what we were able to do, and as you can see, 19 different expert editorial members were there. In comparison, there were only 5 for the 4th edition, so you can tell how there is a greatly expanded and increased number of expert editorial board members. Specifically, each one was responsible for at least one major anatomic site, or perhaps multiple different anatomic sites. And then, of course, input from various other individuals from cytology, radiology were also incorporated in this editorial board. You will notice that there are some asterisks. Those 4 individuals, in fact, are standing board members who happen to have an interest and expertise within this area of head and neck, and or specifically as it related to the hematolymphoid, neuroendocrine, and or soft tissue component. So 251 unique diagnostic entities were included. Specifically, subtypes that had formerly been called variants were included under an entity. About 280 different authors for 30 different countries represented, and of course, a hierarchical classification was implemented. So what that means is that you actually start off with things like the hamartomas and reactive or tumor-like presentations, to those that are benign tumors, the uncertain or borderline tumors, and then finally the malignant tumors, with an assessment to try and calculate the overall malignancy or grade. So going from those that are the more benign category or low grade potential within the malignant category all the way up to the highest grade. So this is a much more logical presentation than the previous one, where it started off with malignant tumors and may have been just related specifically to frequency rather than to biologic behavior. Lots of different instructions were given. I am not going to go over this in excruciating detail, but just so that you know that everyone did actually have the exact same instructions on what it is they were supposed to do, how they were supposed to build the images, whether they were going to create composites or not, how to give guides, no letters and symbols. I mean, it was very, very specific and included a lot of different things for us to do. But as you can tell from the ultimate book, you can see that there are multiple different images. I'm showing just two of them on the far left-hand side, and then you can see the composite guide that the author had submitted below in order to be able to give a better understanding of what may be able to be included. So needless to say, a very comprehensive overall approach to what happened. So let's talk about the book. And in this particular instance, I'm actually going to build a chapter. So the point behind this is not to be annoying, but just to show you how very easy it is for the authors to have gone into the system and to be able to create each of these diagnostic entities. So you will notice I'm doing ear squamous papilloma for this particular diagnosis, and you will see how we are going very rapidly through the various categories that are available that are very heavily standardized throughout. So definitions and related terminology, subtypes, things like localization and talking exactly about where it occurs and why it is significant, including things about imaging. Clinical features are one of the other topics that are discussed, where you talk about what the incidence of the lesion is, what other symptoms may be present for the patient. The epidemiology for each of these lesions revolved around incidence and frequency, as well as whether it was in males or females, and sometimes related to age and demographic related information around race. The overall etiology, sometimes there isn't much, as you can see here that it's only an HPV-associated lesion, but still whatever etiologic factors may be included were incorporated. Pathogenesis allows for information specifically as it relates to potential for genetic pathways or otherwise tumor-associated findings that may be leading to the cause of the disease. The macroscopic appearance we all are very familiar with and allows for a brief understanding of what those particular findings may be. The histology, of course, includes standard H&E related material. If there is anything specific around immunohistochemistry or perhaps about grading, that would also have been incorporated in that area, along with a differential diagnosis. Cytology and some of these factors were very significant within salivary gland and neck-related lesions. Of course, here for a squamous papilloma, it was not really clinically meaningful in that sense. And then, of course, things like the molecular testing, if it is required for diagnosis, that would have been included. Staging and essential diagnostic criteria. This is a new category where you have the exact thing that needs to be present in order to make the diagnosis, and allows for a very quick snapshot of what those particular features may be in order to come up with an accurate diagnosis. And then finally, things around staging and predictive value. Treatment is not given, but rather the information around treatment may be included in order to be able to give an accurate assessment. And so here you can see, in the time that I have spent for just a few moments, you can see that the entire chapter has been built, and that is what happened with the book. So the major changes for this edition specifically are related to aggregating things from all anatomic sites into their own chapters to avoid redundancy. Specifically, this related to salivary gland tumors not being repeated in each anatomic site. The same thing with soft tissue hematolymphoid and melanocytic lesions. They were all incorporated into their own entity chapters so that there is not repetition except for some site-specific exclusions. Metastases to the head and neck were also included as a single overarching chapter, just like germ cell tumors. And then the neuroendocrine tumors and paraganglioma were specifically incorporated into their own chapters, which I'm going to talk about a little bit later on. And finally, the genetic tumor syndromes in which there is a major head and neck manifestation were presented here with 15 different entities described. So what are the best features forever? Well, I know BFF is supposed to stand for something else in common parlance, but nonetheless, I think it's a good opportunity to say that the books are going to be hosted in an interactive format online. This is optimized for both desktop and mobile device, so you can have on-demand, anywhere access for this. The online version, of course, will have much more images than the printed book because there were several more images submitted than can fit in a printed book. The virtual whole slide, I think, is probably one of the most significant things to include in this edition as well, where there is a whole slide for each of the diagnostic categories. As you know, the references link out to PubMed numbers. The essential and desirable diagnostic criteria for each entity allows for a very quick review of what those will be. And then finally, radiologists and cytologists were included so that those particular parameters, especially as it relates to the head and neck, were now going to be incorporated. So let me just drive what it looks like to be on the World Health Organization classification site. You just go to tumorclassification.iarc.hu, and here you would be able to see these. So let's look at the head and neck. Here is an example of each of the various chapters. I'm just going to highlight that the entire book, as I just described, is going to be there. And specifically, let's just go and look at how the layout is. I'm going to choose the head and neck area for neck specifically. Let's just talk about branchioma as an example so that you'll be able to see how it's laid out online. So all of the various categories that I've already spoken about and the specific entity groupings have been listed on the far left-hand side that allow you to be able to see what those features are within the context of the text itself. As you look through the text, you can see that there are many linked references. So the linked references, in fact, are very, very helpful for this because it allows you to be able to go and click on one of those and automatically go through to PubMed. So here is an example. Why don't I just click on this and you'll see we can launch into the PubMed website. Here is an article on the nomenclature with a link through directly to the overall PDF, where now you could actually click on it, download it, open it, and now you would be able to read through the exact source material that was utilized as part of that particular reference in the book so that you're actually able to read it easily and get a feel for what is going on. So I think that's fantastic. Now, the images, you can look at them in a small fashion, or you can actually open them in a much larger appearance, as you can see here, that allows for a very nice opportunity to review several of the images. They are all standardized to be exactly the same overall size, with the number of pixels being identified to be standardized throughout. However, I think one of the best features and one of the best characteristics for this book is this feature, the whole slide image. So this allows you to actually go and look at a whole slide of what the person who wrote that particular chapter feels is the best example of this entity. So here you can see, as I drive very quickly, you can go up to 40x magnification and see the histologic features as they've been described in the chapter and look at them yourself. In fact, you're even able to capture some screenshot captures of these images in order to be able to get to the same diagnostic conclusion. So my view of this is that it's an incredibly fantastic opportunity to be able to look at the book and see everything online in a really interactive fashion. As I've already suggested, the International Collaboration for Cancer Reporting has been utilized for this book as well, allowing for the various entity categories to be specifically filled in. The data sets and reporting have been standardized with explanations and recommendations for the guidelines included in various articles that have already been published. So I think this is a great opportunity to be able to look at these histopathology reporting guides that allow for standardization across the nation. So let me just talk about a couple of the categories in this introductory lecture, just so you'll see what we did, and then we'll go into them in more detail with the other presentations. So tumor-like lesions of the neck were not actually included in the 2005, 9 in the 2017, and 8 diagnoses were included in the 5th edition now. Lymphoepithelial cyst and branchioma were included as new entities in this location, and Merkel cell was moved to the neuroendocrine tumor section. So as you know, lymphoepithelial cyst is a descriptive term for a benign acquired epithelial line cystic lesion associated with a dense lymphoid stroma. Of course, we all are very familiar with this in the parotid gland, lateral neck, or even floor of the mouth. So there is nothing really profound, just that it has been now incorporated as one of the reactive but tumor-like presentations of an entity. Branchioma, this used to go under the name of ectopic hamartomatous thymoma, but since it is not ectopic, it is not hamartomatous, and there's no thymoma documentation within it, the name didn't really quite make a lot of sense, so branchioma has now been incorporated as the diagnosis for this entity. Usually solitary, well-circumscribed lower anterior neck, haphazard proliferation of spindled cells, epithelial islands, and adipocytes without any primitive elements, as that would move it into an example of a teratomatous type lesion. Little squamoid islands and anastomosing nests are also seen with these very nice plump spindle cells. Sometimes myoid features and even fat cells can be seen within it. And of course, in isolated cases, malignancy or carcinoma can be identified. So an example of the imaging on the left-hand side with a very nice example of the low power for a branchioma on the right-hand side. Here you can see a haphazard admixture with a very prominent spindle cell area on the right, much more of a cystic appearance with the epithelial-lined spaces, squamous epithelial islands and adipocytes easily interspersed with one another. And of course, the spindle tumor cells can be seen throughout, staining positively with smooth muscle actin in several of them. So that is the only new entity for that particular category. I'm going to now discuss the neuroendocrine neoplasms and paraganglioma, because this is a very new incorporation and a standardization across the entire book. And so I think this is one of the most significant changes in the book. So neuroendocrine tumor is going to encompass grades 1, 2, and 3. They are site-specific, although in many anatomic sites, the full definitions of each of the grades has not yet been defined. And then, of course, as you know, neuroendocrine carcinoma encompassing small cell neuroendocrine carcinoma, large cell neuroendocrine carcinoma, and Merkel cell carcinoma at this time. So if you think about neuroendocrine tumor as an overall group, these are well-differentiated epithelial and neuroendocrine neoplasms that arise in the upper aerodigestive tract and salivary glands, arising from the dispersed neuroendocrine system. And of course, imaging studies, specifically around 68 dodecate, can be quite helpful because they target the somatostatin receptors that are found within the tumor cells. And so can be quite useful in localization and staging of these lesions. So here you can tell such an example, two different images, one showing that there is a neuroendocrine tumor in the neck, immediately adjacent to the larynx. And then you can see that there is multifocal disease as represented by a lesion occurring elsewhere in the upper aerodigestive tract adjacent to the trachea. Now, of course, metastatic disease can also be seen, and that is what is noted on the right side, where you can see multiple areas of bone and lymph node metastasis from a lesion. So it's a very, very powerful tool that can be utilized at this particular time. So if you talk about neuroendocrine tumor now, rather than neuroendocrine neoplasm, which is the overarching category, neuroendocrine tumor, well-differentiated epithelial neoplasm arranged in cords or nests, trabeculae or small nested forms with neuroendocrine cells that have abundant granular pale acidophilic cytoplasm and kind of a relatively monotonous nuclei that have a salt and pepper nucleochromatin distribution. As in other anatomic sites, grade 1, 2, and 3 are kind of separated out based on the numbers of mitotic figures. So grade 1 net is really anything that lacks necrosis and has less than 2 mitoses per 2 square millimeters, while a grade 2 net may have some necrosis and 2 to 10 mitoses. And then that optimal Ki67 index for those that are grade 3 has not yet really been well defined for the head and neck, although we are anticipating that that will be the case and therefore should be something that will be present. So as you would expect, they are going to have reactivity for epithelial markers such as CK-pan or CAM 5.2, even CK7, and then a variety of different neuroendocrine markers with synaptophysin and chromogranin A most sensitively, while the transcription factors such as INSM1 will be positive in these tumors as well. A variety of other markers can be seen like serotonin and calcitonin, even TTF1. The neuroendocrine tumor category has an intact P53 and RB, which is often lost when you get into the neuroendocrine carcinoma category, and so these are very helpful. So here you will notice a low-grade lesion, very rosetted in its overall formation, small, almost Zellballen type architecture for a grade 1 neuroendocrine tumor that lacks any mitotic activity. Slightly increased degree of pleomorphism seen here in a grade 2 net, where there is an increase in mitotic activity as well, a slight increase in the nuclear to cytoplasmic ratio. Even more prominent nucleoli can be seen in this example of a grade 2 neuroendocrine tumor. Tumor necrosis is quite frequently identified in these lesions as well, as you will notice in the center of this field. Here you will see areas of apoptotic change as well as areas of necrosis in an example of a grade 2 neoplasm. There are just way too many mitotic figures in this case, with tumor necrosis and an overall increase in the nuclear to cytoplasmic ratio of a grade 3 neuroendocrine tumor. And here is another example of a grade 3 where you can see that there are 4 mitotic figures in less than a single high power field in this example. As I've already suggested, CK-pan may be diffusely and strongly positive in these lesions, with either chromogranin or synaptophysin diffusely expressed. Calcitonin can be seen in some of these neuroendocrine tumors, as well as TTF1 aberrantly expressed. Here is an example of an intact RB, which means that this tumor would not be classified in the neuroendocrine carcinoma category, as this is one of the defining features between the lesions. So let's talk about small cell neuroendocrine carcinoma for a moment, having scant cytoplasm, finely granular chromatin, inconspicuous nucleoli, and usually a very high mitotic index. So most of these do occur in the larynx, although the sinonasal tract can also be seen, and recognize that, again, there is a strong association with tobacco use in the larynx, while oropharyngeal tumors can have high-risk HPV associated with them. So the neuroendocrine features must be seen and be predominant histologically. You can't just have a poorly differentiated neoplasm and only have neuroendocrine marker immunoreactivity and not neuroendocrine histology. So both features must be seen concurrently. The small cell neuroendocrine carcinoma cells are smaller than the diameter of 3 lymphocytes, scant cytoplasm, large hyperchromatic nuclei, very, very inconspicuous to absent nucleoli, nuclear molding, greatly increased mitotic figures with crush artifact usually easily identified. And of course, it is possible to have a concurrent neoplasm present. So when I look at this, you will see that it has the same features as you would see of a small cell carcinoma in any anatomic site, with a very high NC ratio and nuclear molding, a very salt and pepper nuclear chromatin distribution. Crush artifact is easily identified throughout. And here you can see very small nucleoli, although they can still be identified in some of these cells. As I've already suggested, a very broad spectrum of both epithelial and neuroendocrine markers may be seen, but in this instance, there is global loss of RB. Well, as I said, the Ki-67 grading has not yet been applied, and yet we do think that anything greater than 20%, at least so far, seems to be an appropriate cutoff. So a strong pan-cytokeratin, synaptophysin, even INSM1, whichever one of these markers you can see, they are all very strong and diffuse. TTF1 can be seen aberrantly expressed in several of these tumors as well. And this is an example of a loss of RB. So you can tell that there is constitutive expression in the endothelial cells while the rest of the background has been completely lost. High Ki-67, and clearly this is not something that would be put into a lower grade neuroendocrine tumor, since this is clearly much more than the 20% cutoff. Sometimes the HPV-associated tumors will have an in situ hybridization technique for high-risk HPV, as you can see in this example, and in that case, it would be interpreted to be a positive finding rather than just relying on the P16 alone. Large cell neuroendocrine carcinoma, defined by cells that are much larger, vesicular chromatin and prominent nucleoli. Just be aware that IDH2 mutations have been seen in several of these lesions, but that SMARCA4 loss is part of the SWE/SNF complex deficient sinonasal carcinoma and should not be incorporated into the neuroendocrine carcinoma category at this time. As I've already suggested, loss of RB and P53 overexpression can certainly be seen in this tumor that has similar morphologic features, although now much larger tumor diameter and very prominent nucleolus present within the lesion. Here you can see a prominent nucleolus, lots of background sort of degenerated cytoplasm. Tumor necrosis is easy to identify within the central portions of the tumor. Again, tumor necrosis with this vesicular to open nuclear chromatin and very prominent nucleoli present throughout. Positivity with CAM 5.2, INSM1, as you would expect to see in a neuroendocrine tumor. Finally, paragangliomas for this group are well-differentiated non-epithelial neoplasms. And of course, these are also seen within the head and neck space. They are quite commonly inherited. And again, the SDHD is one of the most commonly identified mutations in this group. The histology is that of a nested to Zellballen type appearance, and of course, a variety of neuroendocrine markers should be present with concurrent either S100, SOX10, or GFAP sustentacular immunoreactivity. We did ask that SDHB immunohistochemistry or some related equivalent be performed in most of these cases to be able to exclude the hereditary risk for these lesions. So here you can see bilateral tumors in an axial CT. Here is an example of a MRA where you can see this angiography nicely highlighting both of the tumors. And then, of course, one of the radionucleotide-based scans documenting several different tumors in this particular patient. Sometimes you will see radiographic incident material that has been used to embolize the tumors, specifically as they occur in the neck space. This is a common finding with a very characteristic Zellballen architecture for these tumor cells, highlighted very nicely with a sustentacular supporting framework with S100. Tyrosine hydroxylase can be used to highlight the cytoplasmic granules. And of course, the somatostatin receptors have also been documented to be positive in the cytoplasm of these neoplastic cells. GATA3 is usually seen in paraganglioma as well. And of course, a nice example here of SDHB loss, where the neoplastic cells are negative, but the internal control of the vascularity gives you a nice granular cytoplasmic appearance. So I hope that that particular overview sets you up for the rest of the presentations that will be coming in the next few minutes, and I appreciate your time.
Good morning. It's a great honor to be part of this distinguished panel and getting the opportunity to discuss some of my favorite topics, sinonasal tract pathology and salivary gland pathology, in particular updates to the WHO classification of these tumors. So here it is. This is the sinonasal tract classification that we came up with. You can see a couple of new entities which we will discuss, but also a lot of new concepts which are not necessarily immediately apparent on the table of contents. So sinonasal tumors are difficult, one of the most challenging areas of head and neck pathology. You can see there's many reasons for that here. Part of the issue is that it's very valuable real estate, very small spaces, so you end up getting traditionally very small biopsies with tons of artifact. This is a pretty typical biopsy from this region. And one of the other challenges, of course, is new entities and concepts that are greatly affecting our classification. And obviously the WHO meeting was just a moment in time, but things have happened since then and will continue to happen until the next meeting. And so it's good to be kind of aware of these. So it wasn't that long ago, probably last WHO or maybe the one before that, where it was very simple to diagnose a carcinoma in the sinonasal tract, or an epithelial tumor, I should say. There were very few categories and they were all very distinct from each other. And so seemingly relatively easy to put them into one of these buckets and be done. But as we'll see in this talk, things have gotten a lot more complicated in the past 10 years. So let's first talk about squamous cell carcinoma. There's two types in the WHO classification. The first is the most common, and it's keratinizing squamous cell carcinoma. It looks like, you know, squamous cell carcinoma of any other anatomic site and is not really a diagnostic challenge. There's really nothing much exciting going on in this area, so we're not going to really spend any more time on this. Non-keratinizing squamous cell carcinoma is much more interesting. That is the other main type in the WHO classification. So let's discuss that a bit further. So histologically, it can be challenging actually because it doesn't show overt keratinization or very limited, and which brings up a whole differential. And its growth pattern is unusual. It often has this kind of inverted papillary growth, or more classically, these anastomosing ribbons, which have very smooth edges, which make it look not obviously invasive, even though this is the way that this tumor invades. High power, usually mitoses are evident. You can see necrosis, but you have relatively little pleomorphism, which becomes sort of a theme when dealing with these carcinomas. By definition, these tumors are diffusely positive for squamous markers. My preferred is P40. Others prefer CK56. Either one is fine, but you really do need to have this demonstrated to differentiate it from some other entities that can look very similar. Now, a small subset of non-keratinizing squames of the nasal cavity are EBV positive. And when this is the case, we call them lymphoepithelial carcinoma, and they do tend to look like the undifferentiated type of nasopharyngeal carcinoma, where it's more likely to be confused with, a lymphoma or melanoma than another carcinoma. Much more frequent are HPV-related non-keratinizing squamous cell carcinomas, looking virtually identical to what you encounter in the oropharynx, where they have this non-keratinizing appearance as well. Now, another interesting concept that we should touch on at least briefly is a new tumor entity that is in the WHO this time around, known as HPV-related multiphenotypic sinonasal carcinoma, a very peculiar tumor that seemingly only occurs in the sinonasal tract in adults with a slight female predominance. As the name suggests, it harbors high-risk HPV by definition, but it's usually the rare type 33 or other rare types. Type 16 positive multiphenotypics are incredibly rare, which is in contrast, of course, to the squames, which are usually type 16. Now, the reason to know about this, not only is it a diagnostic challenge, but it paradoxically has very indolent behavior. I'll see why that's paradoxical in a moment. Even though local recurrences are common, even very late recurrences, Mets are actually very rare, and it's uncommon for patients to die of this disease. So you don't want to mistake it for a more aggressive carcinoma. So at low power, HPV-related multiphenotypic looks very similar to non-keratinizing squamous cell carcinoma, these kind of basaloid nests, but distinctive are the adenoid cystic-like areas that are frequent in this tumor. So you get these cribriform areas, which very similar to what you see in cystic carcinoma. Yeah, I said paradoxically indolent because most of these tumors look very ugly. Necrosis is common. You can get very marked pleomorphism and very high mitotic rates. So if you don't recognize it for what it is, you'd end up calling it some horrible carcinoma, but they don't behave that way. The other thing that makes it similar to adenoid cystic is it's truly, most of the time, truly a biphasic tumor. They always show some degree of myoepithelial differentiation, but most of them also show a second population of tumor ducts, as you can see here, usually very subtle, just like it is in adenoid cystic. So you can see why this tumor was originally called HPV-related adenoid cystic-like carcinoma. Distinguishing it from adenoid cystic is relatively straightforward, demonstrating HPV, but also most of these will show areas of this bizarre squamous dysplasia on the overlying surface epithelium, which is, of course, not something you would expect to see in a true salivary gland cancer. The immunostains can really help bring out the biphasic nature of this tumor. Cytokeratin is very strong in the ducts, weak in the myoepithelial cells, and of course, calponin, smooth muscle actin, P40, et cetera, are all going to have the staining in the myoepithelial. As an HPV-related tumor, they are diffusely P16 positive, but that's not enough in this site because a lot of things are P16 positive. You really need to show that it has high-risk HPV by a more specific technique, including RNA in situ hybridization. Make sure your probe covers type 33 and some of the rarer types. You don't want just a 16 probe. So just to be very, very explicit on the diagnostic criteria, it's a carcinoma that has myoepithelial differentiation by immunohistochemistry and high-risk HPV by a specific assay, not just P16 alone. Desirable would be the sinonasal tract location, a population of ducts, and of course the overlying squamous dysplasia. That was the nice thing about getting it into the book this time. I was actually able to give the diagnostic criteria, which had been sort of a challenge and people misdiagnosing this tumor. So in addition to the virally driven tumors that resemble non-keratinizing squame, there are also increasing number of fusion-driven tumors. The first of which is an entity that was in the WHO for the first time in the 2017, nut carcinoma. I think we all know about it, but it's still relatively underdiagnosed, has a devastating prognosis. Okay, nut carcinoma, known for having, again, that kind of monotony despite high-grade features. The telltale sign is the abrupt keratinization that you see only in about a third of cases, but when you do see it, it's obviously very helpful. Now, most cases look overtly malignant, not a problem, but this was a case I had recently, very scary, very monotonous, very few mitotic figures, and ended up being a nut carcinoma. So I always consider nut carcinoma when I'm about to diagnose a non-keratinizing squamous cell carcinoma. Fortunately, there is a very nice immunostain, very sensitive and specific, showing the speckled nuclear pattern that obviates the need to do any molecular testing to prove nut carcinoma. The next fusion-driven tumor that mimics non-keratinizing squamous is adamantinoma-like Ewing sarcoma. Like nut carcinoma, it's rare, but not super rare, and it by far affects the head and neck more often than any other site. It's not limited to the sinonasal tract. You can get it salivary, thyroid. And the other weird thing is usually in adults, not kids, where you would expect to see a Ewing sarcoma. Also, like HPV-related multiphenotypic, it's relatively indolent, much more so than a conventional Ewing sarcoma. And actually, there's kind of some debate with the soft tissue people about whether it's a real Ewing or not. Regardless, it's a very recognizable tumor. In some ways resembles conventional Ewing, nested kind of clear cells with rosettes, but in other ways looks weird. You can have overt squamous differentiation. By immunohistochemistry, it's always going to be CD99 positive, NKX2.2, and some degree of synaptophysin staining is all good for a Ewing sarcoma. But unexpected, you have diffuse keratin positivity and squamous marker staining like P40. So I tell people, if you have a tumor, a basaloid, undifferentiated looking tumor that has both neuroendocrine differentiation and diffuse squamous marker positivity, that should set off your spidey senses, because there's hardly any other tumor that will have that pattern. And so if you have that, then get your CD99. The next entity that is fusion-driven in this group is Decaf2 carcinoma. It's really recently described, initially in this paper where it was really buried and you had to really search for it. More recently, it's been kind of an explosion of recognition of this tumor. So like the other things, it's rare, but not as rare as we initially thought. This is from our paper, which is, I guess, the largest, just showing you the wide age range that you can see, the aggressive nature of many of these tumors with frequent regional lymph node mets and tumor-associated deaths. This is from the other major paper on this concept, showing you how many of these are mistaken for sinonasal papillomas, and you'll see why that is true in a second. Histologically, they are frequently papillary, very exophytic papillary tumors, and they often show also in the stroma this classic non-keratinizing squamous cell carcinoma growth pattern with these pushing nests that don't look obviously infiltrative but are. They are frequently infiltrated by neutrophils, which is a helpful clue. They can look very, very bland. This is from the same tumor, showing you how they can look very primitive and basaloid on the right, but also very bland and inverted papilloma-like, as you can see on the left. Another feature we see sometimes is this kind of hyperchromatic kind of basal layer that almost makes it look a little bit ameloblastic. And then this weird pattern, which I call blue swirlies, is very distinctive for Decaf2 carcinoma. Not seen in every case, but when you see it, these kind of very bluish, keratin pearls in the middle of an otherwise pink tumor, that's very helpful for thinking of Decaf2 carcinoma. The existence of Decaf2 carcinoma helps to explain things that we didn't understand before, like the concept of, so-called metastasizing inverted papilloma. We realize now all of these are Decaf2 carcinomas. Also, this tumor that was previously called low-grade papillary Schneiderian carcinoma, all of these are actually Decaf2 carcinomas. Nevertheless, there are many questions that remain, as listed here. I'm not going to read them all, but it wasn't a full-fledged entity in the upcoming WHO. All this was really just coming out right at that time, but I think it's probable that next time around it will be its own entity. So what is the best way to diagnose it? Well, here's a case that was positive by FISH, but negative by RNA sequencing. So maybe FISH is more sensitive. There is an immunostain. The group in Taiwan is publishing this now. Remains to be seen how useful it is. Of course, they say it's great. We'll have to try it and see. If it is, great, because like nut carcinoma, the immunostain made it much easier to diagnose. I'd love to be able to call this tumor without doing genetics. We realize that not all the tumors are non-keratinizing. This one was one that had a lot of keratinization. This is an example that had clear gland formation, so they can be adenosquamous carcinomas. Here's a recent case I had that had areas of overt sarcomatoid differentiation. So clearly we don't know the full histologic spectrum of Decaf 2 carcinoma. Here's a recent case we published of an undifferentiated neuroendocrine tumor metastasizing to a lymph node. It was keratin negative, but neuroendocrine marker positive. And to my surprise, by sequencing, ended up having an AF2 fusion, a novel AF2 fusion. So perhaps this is going to be a family of AF2 fusion-related tumors. So I think what we're finding is that non-keratinizing sinonasal squamous cell carcinoma is actually a genetic wastebasket full of virus-driven tumors, nut carcinomas, adamantinoma like Ewing, and now Decaf 2 carcinomas, and probably some other things that we haven't found just yet. So whereas this was a very simplistic way of looking at it before, now we have all these other considerations and all these interconnected tendrils between. Let's now discuss Sinonasal carcinosarcoma. This is not a new entity. In fact, it's kind of old, but we have a whole new understanding of it as of the last couple of years. Because of that, we are able to make the diagnosis more than we were previously able to, and I'll discuss why that is in a moment. But yeah, this used to be something we'd call, I don't know, every couple of years, and now, we see it somewhat frequently. Historically, it was sort of unclear of what its histogenesis was, and I guess it's still not totally resolved. The name suggests it might be related to a germ cell tumor, which we're fairly certain is not the case. But also some suggestion, due to some overlap of histologic features, that it could be a cousin or related to olfactory neuroblastoma and arise from that same epithelium. Originally, in the first reports, it was a very aggressive tumor, very fatal. But I think with the more aggressive therapeutic regimens, it's actually not so bad these days. Teratocarcinosarcoma is a very well-named tumor. The terato refers to these teratoid epithelial elements, which can be, mature or immature looking. You can see at the top, there's this kind of colonic looking glandular stuff. And in the middle, these squamous nests with this prominent clear cell growth. This is said to be like fetal looking. The carcinomatous elements also include a prominent neuroendocrine differentiation seen in much of the tumor, including, rosettes in areas. And then the sarcoma, of course, refers to the malignant spindle cell component, which can show overt sarcomatoid differentiation. Here, beautiful rhabdomyoblast in the middle. You can also see cartilage, bone, or more often just kind of a undifferentiated spindle cell tumor. Until recently, we didn't really have a good marker for this. Each component stained the way you would expect. The neuroendocrine stains were neuroendocrine. The rhabdomyoblasts were, myogenin positive. And classically, it was very difficult to make this diagnosis, particularly on a biopsy, because really you needed to see every single element to comfortably make the diagnosis. And it's like the fable of the blind man feeling each different part of the elephant. Depending on what you saw in a small biopsy, that's the diagnosis you would make. If you saw the neuroendocrine stuff, you'd call it a neuroendocrine tumor. If you saw the rhabdomyoblast, you'd call it a rhabdomyosarcoma. And you could only really see it with a very good sample, that had all the elements. However, now we have more of an appreciation of the genetics of this tumor. It's kind of interesting. In our first paper on this a couple years ago, we showed that over 3/4 of the cases had some degree of SMARCA4 loss by immunohistochemistry, which was fairly specific for this tumor. More recently, we've done more genetic testing of these tumors, and still the vast majority have SMARCA4 mutations and loss of expression of the protein. But the second most common thing is beta-catenin gene mutations. And the interesting thing is they're not mutually exclusive, and the IHC doesn't always correlate with the genetics. So this is kind of what we're finding, and you can see most of them do have some loss of SMARCA4 and a mutation in most, but not all of those tested. Similarly, beta-catenin overlaps. Some of them have both. You can have mutations with or without nuclear overexpression. So SMARCA4 immunostain, when you show complete loss, it looks like this. You can see the epithelial and the spindle cell elements are lost, negative, and the normal lymphocytes are retained. This is very useful, so particularly on a small biopsy, if you have a tumor with some of the elements or they're not very well developed, you're not sure, is it the spindle cell part of the tumor or is it not? You do a SMARCA4 and you show nice loss in these elements, it allows you to make a more confident diagnosis of teratocarcinosarcoma, even without seeing every single tissue element. Sometimes, though, you see partial loss, and you can see here on the top, it's kind of diminished expression. In the middle, it's complete loss. So that's also, fine for teratocarcinosarcoma. As I mentioned, a lot of these will show nuclear expression of beta-catenin, which doesn't always correlate with mutation. I would be more cautious about using this as a diagnostic tool because, in my experience, this isn't so specific for teratocarcinosarcoma. Now let's talk about sinonasal neuroendocrine carcinomas. They're uncommon. Conceptually, we can think of them as being identical to those of the lung and other sites. They're classic aggressive tumors. So here's a classic small cell showing geographic necrosis, nuclear molding, all the usual things. Here's a classic large cell neuroendocrine with more cytoplasm, more open chromatin, prominent nucleoli, and yet still showing overt high-grade features and neuroendocrine differentiation. So these neuroendocrine carcinomas were actually taken out of the sinonasal section this time around and are in their own neuroendocrine section. Not really what I would have done, partially because that implies that these sinonasal carcinomas fit neatly into this classification. The fact is, they usually don't. Pure small cell or large cell neuroendocrine carcinomas are very rare in the sinonasal tract, and when they do happen, they're almost always HPV related. When they're not HPV related, they usually do not fit neatly into one of those two categories. So here's an example showing, these like kind of Rossetti formation. It was neuroendocrine by neuroendocrine staining, and yet it's not small cell, it's not large cell. So where do you put it in the classification? There really is nowhere, right? It doesn't fit. And yet it is a neuroendocrine carcinoma. Here's another case we see sometimes. These are really odd. They very nested neuroendocrine by staining, showing these like overt gland formation, as you can see in the top right, and even neuropil on the bottom right with high, grade features. So what do you call this? It's diffusely keratin positive, and yet shows sustentacular S100 staining. It doesn't fit into any of the neuroendocrine carcinoma categories, and it doesn't fit into olfactory neuroblastoma, at least not classically. It has way too much keratin expression. But as you can see in the upcoming WHO, we do mention rarely cases can be more diffusely positive, blurring the distinction between olfactory neuroblastoma and neuroendocrine carcinoma. And with that in mind, we did recently publish on this concept, calling them olfactory carcinomas. Basically, these difficult to classify tumors that have mixed features of carcinoma and olfactory neuroblastoma. Also problematic are tumors that used to be considered part of the neuroendocrine carcinoma group, but now we realize they're separate. The first of these is a SMARCB1 deficient sinonasal carcinoma. This is SMARCB1 is part of the SWE/SNF chromatin remodeling complex, which you'll hear more about in a moment. And activation of SMARCB1 is seen in a lot of entities that tend to share rhabdoid cytomorphology. Classically include rhabdoid tumor and epithelioid sarcoma, but many other tumors as well. Now, this was included as a provisional entity in the last WHO and now is fully grown up. Has a wide age range with frequent involvement of the ethmoid sinus as well as other sites in the sinonasal tract. Very aggressive tumor, presents at high stage and frequently causes tumor-related death. By morphology, they're pretty undifferentiated looking tumors, high grade, frequently have these empty vacuoles, which can be a histological clue. About a third of the cases do have that rhabdoid cytomorphology similar to what you see in other SMARCB1 deficient tumors, but the rest of them seem to have more of a basaloid morphology, although even in those cases, you can see scattered rhabdoid cells throughout if you look hard. Very variable immunohistochemistry, P40 can be focal or diffuse, and a lot of times they can show varying degrees of neuroendocrine differentiation, which again can cause you to mistake them for a neuroendocrine carcinoma. SMARCB1 is lost by definition with nice internal control in the fibroblasts and lymphocytes. But one weird thing about these tumors, they can sometimes show glandular differentiation, like you can see here, often with yolk sac-like differentiation. And so if you see something that looks like yolk sac, you'll often find that it's positive for yolk sac markers, even like SAL4 and glypican-3. But a genuine yolk sac tumor in the sinonasal tract is very, very, very rare, much more likely to be a SMARCB1 deficient. Another SWE/SNF related tumor that is also new to the WHO is SMARCA4 deficient sinonasal carcinoma. This is a different family of tumors that includes different things, as you can see listed here. They're uncommon, much less common than SMARCB1 deficient tumors, but they really, really look neuroendocrine, as I'll show you in a moment. It's rare that you see a case that has that rhabdoid look that you expect to see in a SMARCB1 deficient tumor. Much more often, they're very blue, very nested, and they even show rosettes, and they really look neuroendocrine. Here's another example, really looking very neuroendocrine, more than some of the neuroendocrine carcinomas I showed you. And if you do neuroendocrine markers, you'll find positivity frequently for synaptophysin. And the key feature here, of course, is thinking about doing a SMARCA4, which will show complete loss in this set of tumors. There's also some emerging data about a tumor that is variably called SNUC, or neuroendocrine carcinoma, or even adenocarcinoma that has IDH mutations, particularly IDH2 mutations. The thought is that maybe whatever we think true SNUC is, if that's even a thing, is IDH mutated carcinomas. Seemingly, they're less aggressive than other SNUC-like tumors that we've been talking about. The other cool thing is IDH mutations are potentially targetable. So if you look at these tumors, they also look very neuroendocrine. They're very nested. They have these kind of rosette-like structures here again, looking very similar to some of the neuroendocrine carcinomas I showed you. Frequently show varying degrees of neuroendocrine marker positivity, and yet are IDH2 mutated. Here's the immunostain, which is kind of so-so. When it's really positive, it's obvious, but sometimes you get kind of low-level positivity. So really, mutation analysis is best for identifying this tumor. It is not an entity in the current WHO, although like some of the other things I'm talking about, very well may be next time around, so good to know about. So yes, while things used to be relatively simple, we already got very complicated on the right, dealing with squamous cell carcinomas. We have all these new entities to consider and their relationships with all the other tumors. So things have very quickly gotten very complicated, but also very interesting. And I don't think that we're done with this diagnostic or classification revolution that we have started. So if I may summarize the changes in the most recent WHO classification, we covered a lot of ground in not very much time. There are some new entities, both of which were provisional entities last time around. We have HPV-related multiphenotypic Sinonasal Carcinoma. Remember, this is the one that's only seen in the sinonasal tract. It's HPV-related, but usually type 33, has myoepithelial and frequent ductal differentiation. So the differential is not only squamous cell carcinoma, but a salivary gland carcinoma, and also has relatively good prognosis. Then we have the SWE/SNP-related sinonasal carcinomas, SMARCB1 deficient sinonasal carcinoma, and also SMARCA4 deficient sinonasal carcinoma. The SMARCB1s are the ones that are more likely to be confused with SNUC, can have that plasmacytoid or rhabdoid look, but more often kind of undifferentiated and basaloid appearing, and can rarely have glandular differentiation with or without yolk sac marker expression. And remember, the SMARCA4 deficient ones are the ones that look more neuroendocrine for the most part. We do have some provisional entities this time around. Decaf2 carcinoma. Remember, it usually looks like a non-keratinizing squamous cell carcinoma, but it's virus negative and negative for all the other things we talked about, like Ewing markers, et cetera. This one, like I said, was really late breaking in the publishing process, and I really strongly suspect it will be its own entity next time around. And then, yeah, IDH mutant carcinomas. These are kind of confusing because, again, they can be diagnosed as SNUC or neuroendocrine or even adenocarcinoma sometimes, and yet probably are their own distinct thing. IDH mutations are targetable, et cetera. And then some concepts that are evolving and are still ongoing. Teratocarcinosarcoma, particularly with the genetics that we're finding and how we can use immunostains, particularly SMARCA4, to aid our diagnosis in small biopsies. Neuroendocrine carcinomas, I think we're still far from having that fully solved. We have a lot of them that don't fit neatly into small cell or large cell neuroendocrine, including this concept of olfactory carcinoma, which is just emerging. And then last thing we didn't even have a chance to talk about, but sinonasal adenocarcinomas, a number of them are harboring these characteristic gene fusions. So the question will next be, are they their own unique subtypes of this group or not? And that's something for next time. So thank you for your attention. Thanks for attending this conference, and I will see you later for the salivary gland talk. Thank you.
Hello, I'm Bruce Wenig at the Moffitt Cancer Center in Tampa, Florida. Before I get started, I wanted to thank Dr. Say and International Academy of Pathology Hong Kong Division for the invitation to lecture at your conference. I've been assigned updates from the WHO for the larynx and the ear and temporal bone, and this lecture will be on the larynx. There haven't been too many changes relative to the prior edition of the WHO 2017 edition and the upcoming 2022 edition. The overview for the fourth edition is listed here relative to the larynx, trachea, and parapharyngeal spaces, which include malignant surface epithelial tumors, precursor lesions. In that book, neuroendocrine tumors, salivary gland tumors, soft tissue tumors, cartilaginous tumors, and hematolymphoid tumors were incorporated into the section. And that was true throughout the book. There wasn't a complete separation of specific tumor types outside the confines of the organ site. But in the fifth edition, many of the entities listed on the left were moved into dedicated chapters, such as neuroendocrine neoplasms, which fell under a dedicated section on neuroendocrine neoplasms addressing all sites of the head and neck, the same thing with salivary glands. So what remains in the upcoming edition are the precursor lesions, squamous cell carcinoma, and those are similar to what was previously provided, as well as the mesenchymal tumor. So there's not a lot for me to choose relative to updates. I will address neuroendocrine neoplasms relative to my talk on the ear and temporal bone. So what I'd like to do is focus on something that's not new, but relatively controversial, and there are minimal changes from 2017 to 2022. So that group of lesions are laryngeal epithelial dysplasia. And these are arguably the most common lesions that a head and neck pathologist, and even a general surgical pathologist who sees head and neck lesions with, are confronted with, both oral epithelial dysplasia and laryngeal epithelial dysplasia, or precursor lesions. And since my focus is on larynx, I will deal with these changes in the laryngeal mucosa. And as you know, these are both architectural, and that's an important point to point out, and cytomorphologic changes of the surface epithelium due to genetic alterations that are associated with increased risk to progression to invasive squamous cell carcinoma. And if you've dealt with these lesions, there's typically a lack of consensus from case to case between pathologists, among pathologists, and even the same pathologist coming back to the same lesion at some future point. So I know I only have a half an hour, so I want to spend a lot of time on some of the details. But just an overview, this is typically a lesion of adults. In the larynx, the most common location for these changes are the vocal cords. And that makes sense because in the glottic region, or the true vocal cords, patients present earlier in the disease course relative to the morphologic changes that occur, so that there may be change in quality of the voice. The person hears it, somebody else hears it. It's called to their attention. They notice it. They go see a clinician, and a lesion is identified. The supraglottic larynx and the subglottic larynx, lesions that may be considered precursor lesions, tend to be clinically quiescent, so that patients don't present early in the disease course. Same thing in the oral cavity, which is why we see more of these lesions relative in those anatomic sites. In oral cavity, a lesion is noticeable, patient can see it, feel it, somebody else can see it, so they go to a clinician earlier. So symptoms typically include some variation of voice quality changes. Just briefly, and I'll come back to this, the etiology of these changes relate to tobacco and alcohol, and less so gastroesophageal reflux. But these typically, with rare exceptions, have no relationship to high-risk human papillomavirus. And as we'll show you, in general, the utility of P16 is non-existent. So P16 is not a decider, unlike the uterine cervix, in determining A, dysplasia, B, the extent of dysplasia. Pathogenesis, there are a lot of genetic alterations that occur. And I'm not going to spend any time on that for now. The treatment for dysplastic lesions and also superficially invasive squamous carcinoma now predominantly is laser microsurgery. Critically, the risk of malignant transformation, meaning to invasive squamous carcinoma, increases with the degree of dysplasia, which makes sense. Typical, similar in some ways to uterine cervix, but there are distinct morphologic differences. So let's move into some of the changes. So in 2017 and in 2022, there are nice tables listing the details relative to architectural and cytomorphologic changes. These have not substantially changed. One of the indicators for dysplasia that was listed in 2022, but not in 2017, is reduced keratocinic cohesion that's typically seen in oral cavity, but can be seen in larynx. But there's been no distinct or significant variation relative to architectural and cytomorphologic changes between the two editions. And I'm just digressing a little bit to oral epithelial dysplasia, where both a 3 grading system on the left, mild, moderate, and severe, and a 2 grading system, low grade and high grade, have been advocated. They both have advantages and disadvantages. It's what your practice is, what you've been using is the type of grading scheme that you use. But the authors, at least in 2017 and to a large extent 2022, provide an option of using a 3-tier or a 2-tiered system. Relative to the larynx, the 2017 edition, and it might be difficult to appreciate, but on the left, there's this graph showing low-grade dysplasia and high-grade dysplasia. The high-grade to include moderate, severe, and carcinoma in situ. So a 2-tier system was advocated. And as you see, the comparison between different grading schemes, the one on the extreme right was advocated to include low grade and high grade. High grade, again, moderate, severe, and carcinoma in situ. And we'll come back to the concept of carcinoma in situ a little bit later on. But that was different in comparison to what was in 2005, which is the second row from the left, which included hyperplasia, the 3 categories of dysplasia, mild, moderate, and severe, and a separate category of carcinoma in situ. And I just want to point out on the extreme left, the extent of the changes in the epithelium, so that the lower third was mild, up to a half moderate, a half to nearly complete severe and full thickness carcinoma in situ, or even severe dysplasia. And in 2017, we've moved to a 2-tiered system without a subclassification of carcinoma in situ. Pretty much this holds up in 2022, with the exception that carcinoma in situ is advocated as a distinct category. But low grade, you see in the top portion, changes occupy the lower half of the epithelium. And I disagree with that. I think that once it hits half of the epithelium, it's at least moderate dysplasia. Again, there are sharp contrasts relative to the type of dysplasia that we see in the upper airway. But low grade, according to the WHO, is half, and we can argue that that's not accepted by all. High grade, meaning half, more than half, and carcinoma in situ, full thickness intraepithelial dysplasia. And this is a chart that is included in the current 2022. I think it's been published already. So that low risk includes lower half, and again, that's arguable. In a 3-tiered system, low-grade dysplasia. In the high risk can include more than half, full thickness, collated under a single designation of high-grade dysplasia. And as the authors advocate, carcinoma in situ can be separated out as a distinct morphologic entity. So from a histomorphologic standpoint, this is normal glottic mucosa. You're all pathologists, you're well familiar with normal epithelium. There's a sharp contrast between the basement membrane, which is the proliferative zone, which has increased cellularity, mitotic figures with maturation to the surface. And typically, the laryngeal mucosa is non-keratinizing. So any degree of keratin is considered abnormal. And that can be seen clinically on the left, a leukoplakic lesion bilateral, and on the right, bilateral red and white. And typically a red lesion or combination red and white lesion is more worrisome for a significant histopathologic finding. So these are just some examples, both in terms of the degree of keratin and architectural changes that one can see in laryngeal keratosis, devoid of dysplasia. So on the left, the relatively flat keratin surface, which is parakeratosis. In the middle, more of an orthokeratotic, thicker keratin layer, but there's a little bit of keratosis, parakeratosis on the left. And these lesions can take the form clinically of verrucoid or papillary appearance, yet not be either verrucous carcinoma or dysplasia. So the morphology of the epithelium, although different than the normal in the sense that there's elongated reedy ridges, lacks intraepithelial dysplasia. There may or may not be a degree of inflammatory component. Generally in the larynx, that doesn't factor into the diagnosis. Relative to upper airway dysplasia, we can see two types. Classic or non-keratinizing, which is subdivided into mild, moderate, and severe, which equates to carcinoma in situ. This is distinctly uncommon in most upper airway sites, in particular the larynx and the oral cavity. So this kind of lesion, which is full thickness intraepithelial dysplasia, from basement membrane to the surface, devoid of surface keratin or any differentiation or maturation, is carcinoma in situ. This is extraordinarily uncommon in the oral cavity and in the larynx. What we typically see throughout the upper airway is a keratinizing, and some authors use the term differentiated intraepithelial dysplasia, which is much more common than non-keratinizing. And again, we try to use or have used a grading scheme of mild, moderate, and severe dysplasia. So just shows some examples of those. There's a varying degree of keratin on the surface, but the dysplastic epithelial changes are limited to the lower zone. Increased cellularity, hyperchromasia, increased nuclear cytoplasmic ratio, irregular nuclear contours, varying degrees in all three mitotic figures, including away from the basement membrane. So from a qualitative standpoint, there are clearly dysplastic changes from normal, and this is limited to the basal zone area. So this equates to mild dysplasia. And again, just comparison to normal, this is clearly, these three examples are not normal. Once you get to at least half, or if not more than half, dysplastic changes and architectural alterations, including irregular downwardly extending reedy, then it hits at least moderate dysplasia, and in a two-tier system equates to high-grade intraepithelial dysplasia. Seen here too, one could argue that this is near total surface, but yet there's still some maturation. So from a purely definitional standpoint, it's approaching, quote, severe dysplasia, and carcinoma in situ, but not quite. So this is more than half. It's probably more like 2/3, but still not full thickness intraepithelial dysplasia. So if one is a restrictive in the definition, one can make this a moderate dysplasia. But in a two-tiered system, it's certainly high-grade intraepithelial dysplasia. And examples of where there's near full thickness, but not quite, there's still maturation, severe dysplasia. And the comparison of the last image of the prior slide, and these are not too different, so that trying to separate it moderate from severe dysplasias can be nearly impossible. So grouping them under a single category makes sense. And again, the true, by definition, carcinoma in situ is rare in these locations because typically there's some degree of maturation or keratinization. So there is no statistical difference in many papers reported to the progression of invasive carcinoma between keratinizing moderate dysplasia and keratinizing severe dysplasia / carcinoma in situ, and we'll come back to that in a little bit. So there is justification for utilizing a two-tiered system, low grade meaning mild dysplasia, high grade meaning moderate, severe dysplasia, and if by some chance this carcinoma and true carcinoma in situ will be high grade dysplasia. And there's good data showing a better reproducibility among reviewers or viewers than in a three-tiered system. So the goal of any grading system is to be reproducible and applicable, and equally important is to be on the same page with our clinical colleagues who are managing these patients, so they understand the diagnosis that we're rendering and how best to utilize that in terms of treating their patients. And over time, the more we work with our clinicians at our individual institutes, the more collaborative understanding there is between, our morphologic diagnosis and the impact in terms of treatment and therapy. There's a nice paper recently published, European Archives of Otorhinolaryngology, reviewing a wide variety of clinical and histopathologic features relative to laryngeal dysplasia. And the authors did indicate that in their meta-analysis, looking at the literature, there's good information showing better reproducibility, but they indicated in a two-tiered system, but it may be less specific diagnostically. We look at the 2022 edition, just a direct quote: "The disadvantage of the two-tiered system of grading is the wide category of high-grade dysplasia, essentially lumping moderate, severe, and carcinoma in situ, which they indicate can be resolved by reintroducing, because it was taken away in 2017, the concept of carcinoma in situ as a third category." Another paper recently looked at inter and intra-rater reliability relative to reviewing laryngeal precursor lesions. There were only two raters, so one could argue that from a statistical standpoint, that doesn't reach significance when you only have two people reviewing and trying to develop kappa differences. But they utilized the 2005 classification, and the paper indicated that the two pathologists were unable to make distinctions between adjacent diagnostic categories like low grade and moderate dysplasia, and moderate dysplasia from severe dysplasia, and severe dysplasia from carcinoma in situ. Again, in 2018, these authors looked at the intraepithelial dysplasia, and they indicated that the low-grade dysplasia category, the two-tiered system, they couldn't reliably distinguish between reactive atypia or basal cell hyperplasia and low-grade dysplasia, and that's clearly true. So one digression that I use, particularly in frozen section, is that the surgeons aren't going to treat anything additional relative to low-grade dysplasia. So trying to differentiate, at the time of frozen section, or even, in permanent section, low-grade dysplasia from what's reactive atypia is almost impossible, and from a clinical standpoint, irrelevant. So yes, these authors are correct. So one of the flaws of the system, if you use a two-tier system, is trying to separate reactive atypia from low-grade dysplasia. But from a practical standpoint, there's no clinical relevance or significance to making that distinction. So no grading system is well designed. The most important take-home message, which you probably are aware of, is for us to be consistent in our diagnoses, so that at least within the same group, there is reproducibility. And that information and close working relationship with our clinical colleagues is key for them to understand what terms we're using, how that applies to their patient's risk for progression of disease. So carcinoma in situ, in the absence of full thickness intraepithelial dysplasia, which we almost never see with these keratinizing or differentiated dysplastic lesions, is the use of the term carcinoma in situ, by definition, meaning full thickness intraepithelial dysplasia, justified. Does keratinizing high-grade dysplasia equate to carcinoma in situ? And it's important to separate high-grade dysplasia from carcinoma in situ. So I refer back to that paper in 2018, in which the authors looked at a wide variety of clinical and pathologic issues relative to dysplasia. So relative to the question they asked in that paper, should carcinoma in situ be used relative to these specific keratinizing lesions? They indicated it's a contentious term. They didn't come down on advocated one side or another. But relative to my questions, in the absence of full thickness intraepithelial dysplasia, is the use of carcinoma in situ justified? It's not. Just by morphologic definition, just purely on the basis of that, in my view, given the rarity of this lesion in the larynx and oral cavity, the use of the term carcinoma in situ purely by definition is not justified. Does keratinizing severe dysplasia equate to carcinoma in situ? No, not histologically, because by definition, severe dysplasia has some degree of maturation relative to these keratinizing lesions, but carcinoma in situ does not. And I may be splitting hairs here, but just taking it from a purely light microscopic evaluation, I'm asking these questions. So is it important in separating high-grade dysplasia from carcinoma in situ? And the answer is probably not. I said maybe not here, but probably not. Go back to the dictum I mentioned before. It's more important for our clinical colleagues to understand what we're talking about. And here, sometimes I get asked, well, is that keratinizing high-grade dysplasia carcinoma in situ by our clinical colleagues or radiation oncologists? And I asked, is there a difference in your mind relative to that? And usually they'll say yes, because it's embedded in their mind that carcinoma in situ is a more worrisome lesion relative to the risk of progression to invasive cancer. And so they want to know if it's carcinoma in situ. So sometimes, not uniformly, and maybe we should make it more uniformly, I've adapted a terminology that it's carcinoma, keratinizing high-grade dysplasia that's essentially or tantamount to carcinoma in situ. That tends to minimize the phone calls I get or the confusion there may be on the clinical side, because then in the mind of the clinician, okay, I'm dealing with a carcinoma in situ. When in terms of the reality, keratinizing high-grade dysplasia from a progressing standpoint is equally at risk to what might be considered carcinoma in situ to the development of invasive carcinoma. So I'm near the end, but I just wanted to touch on a couple of issues. Upper airway dysplasia is not the same as cervical intraepithelial dysplasia from a variety of standpoints. One, the uterus cervical dysplasias are HPV driven. You can use P16 and Ki67 in terms of trying to help differentiate grades so that P16 and Ki67 will be limited to the lower zone. And as we get to higher grade lesions and full thickness, you would see more extensive expression in that epithelium. And in this continuum, one has to have full thickness intraepithelial dysplasia before we get into invasive carcinoma. And these are typically non-keratinizing dysplastic lesions. So this is an upper airway lesion. What's your diagnosis here? It's clearly keratinizing. There's clinically, this is a leukoplakic, it may be, speculucoplakic lesions. Most of this epithelium, 2/3 of this epithelium lacks any dysplasia. Yet, from an architectural standpoint and a cytomorphologic standpoint, this is dysplastic. And if we use the dictum of 1/3, half to 2/3, more than 2/3 to full thickness as low grade and high grade, one might consider this to be limited to low grade with the limited risk to progression to invasive cancer. Yet when I have cases like this, to this extent, this to me is a high grade dysplastic lesion, because this lesion will progress to invasive cancer, more statistically significant level than a true low grade dysplasia. So that's a high grade dysplasia. And the reason I say that, because in the upper airway, we have these drop-off carcinomas in which one does not have to have any dysplasia beyond the basement membrane to get invasive cancer. And here are two examples. Here's the focus of invasive cancer originating by direct extension from dysplasia limited to the lower zone, yet most of the surface epithelium is bland. This creates difficulties, or has, in terms of consensus in evaluating, lesions like this. So going to a two-tiered system is helpful because it takes away some of the subjectivity, in analysis. Yet we need to understand that in looking at upper airway dysplasia, it's totally different from a morphologic, from a biologic standpoint, from an etiologic standpoint than uterine and cervical dysplasia. So the last part of this talk, I just want to focus briefly on biomarkers in upper airway dysplasia. This is, again, that same lesion. If we were to apply Ki67, it would be entirely limited to the lower zone. So it's really of no diagnostic utility. Again, this cancer will invade if it's not treated. And if you're hanging your hat on Ki67 or even P16, which is going to be negative, or the blush on the right is a negative stain, these are not driven by high-risk HPV. These are tobacco and or alcohol derived. So again, Ki67 limited to the lower zone. P16 of limited utility in the diagnosis because it's not, an etiologic agent. Yes, there are rare examples, or maybe not so rare, but uncommon examples in which, you might apply P16 in a given laryngeal lesion. It'll be positive. P16 alone, overexpression, is not always driven by high-risk HPV. There are alternative genetic mechanisms by which there may be overexpression of P16. In our practice, we always use high-risk in situ HPV to confirm the presence of P16, even in more typical locations, but definitely in odd locations. If you were to get a true P16 positive, that's nuclear cytoplasmic staining in more than 70% of the lesional cells, then my suggestion would be, especially if it's unusual morphology or anatomic location, to confirm with high-risk HPV in situ. So biomarkers, Ki67, P16, and P53, and then talk about that, but usually it's wild type when you do the analysis, are of limited to no utility, as are some other biomarkers, EGFR, cytokeratin 19, and MAGE8. The reliability and prognostic value for these biomarkers are lacking, and they're not recommended for dysplasia classification. I reaffirm the typical keratinizing dysplastic lesions of the upper airway. They're not recommended for utility. More recently, this NANOG is a master regulator of embryonic stem cell pluripotency. It has emerged as a diagnostic and prognostic marker for dysplasia of the head and neck. It's evaluated based on protein expression and immunohistochemical. It's a cytoplasmic stain, so that in normal mucosa, there's no expression. In low-grade dysplasia, there's weak cytoplasmic expression. In high-grade dysplasia, CIS, carcinoma in situ, and fully invasive cancer, it's strongly expressed. So those differences may allow for utilization of NANOG in helping us diagnose and distinguish among the various grades and invasive carcinoma. We don't have it yet. I have no experience with it. This is purely literature, but it is emerging as a potential useful marker as a biomarker in dysplasia. More recently, as you might expect, mutational profiling has been introduced into dysplasia. There's some recent studies that suggest that mutational profiling may be useful in early detection of those patients at risk for progression. Before I complete my talk, just one digression. Yes, HPV can be seen in upper airway dysplasias, and particularly oral cavity. There are two papers listed at the bottom in 2013. These are rather distinct lesions, typically in men of the ventral tongue and floor of mouth. The dysplastic changes are a little bit different. They're almost near full thickness. There's karyoretic debris. There are many mitoses, has a more basaloid look to it. It's still keratinizing. If you do a P16, you see the sharp separation between the dysplasia and the normal epithelium, and confirmation by high-risk HPV. There's no tremendous, even though they were published in 2013, there's still uncertainty about the meaning of this and relative to progression to invasive cancer and what the biologic potential of those lesions are. So in summary, what I've tried to do, although there aren't tremendous differences between 2017 and 2022, is focus on precursor lesions, meaning the intraepithelial dysplasias, which are retained from the prior edition, are the cartilaginous lesions. The the dysplastic lesions, the two-tiered system is advocated. It's more reproducible. It's flawed in some degree, so there are advantages and disadvantages. The use of the term carcinoma in situ, by definition, full thickness intraepithelial dysplasia, is not justified on histomorphology alone. And biomarkers, particularly non-analog immunohistochemistry, may be emerging or has emerged as a useful adjunct in helping us make diagnoses in problematic diagnostic cases. And with that, I thank you for your attention. Okay, my second talk on WHO updates will focus on ear and temporal bone. Just to remind you, because not many of us deal with the histoanatomy and histology of the ear and middle ear. The external canal begins at the orifice of the ear, extends to the tympanic membrane. This is basically cutaneous epithelium. As we get to the membrane, which is also cutaneous epithelium, it separates the external auditory canal from the middle ear and temporal bone. The temporal bone houses the cochlea and the semicircular canals. We don't see much pathology relative to that on occasion in the lymphatic sac papillary tumor, but there's a fair amount of pathology that can happen in the middle ear, which connects via the eustachian tube to the lateral wall of the nasal pharynx. So this is just an overview of the histoanatomy relative to the ear and temporal bone. In 2005, the classification or the entities covered are listed here, varying from squamous cell carcinoma, which is arguably the most common malignancy of the external canal, ceruminous adenocarcinoma, which can be purely a ceruminous neoplasm or may give rise to adenoid cystic carcinoma, mucoepidermoid carcinoma, among salivary gland tumor types. And if you're ever making a diagnosis of adenoid cystic carcinoma or mucoepidermoid carcinoma, the external canal, we always have to exclude the possibility of extension from the parotid gland proper. And then the benign counterpart to ceruminous adenocarcinoma is a ceruminous adenoma, and a variety of common and uncommon lesions can occur in the middle ear and temporal bone, including the list here. And otosclerosis has been identified as a neoplasm. Cholesteatoma, we can argue, but those are the two more common pathologic related entities that occur through the population in the middle ear and temporal bone. And then middle ear adenoma, meningioma. The paragangliomas, both in 2017 and 2020, were separated out into separate classifications under paraganglioma in general. We look at the 5th edition, there are some entities that were not previously included. One could argue that the top 2 are not neoplastic. Same thing for exostosis, but ceruminous adenoma, adenocarcinoma, and squamous cell carcinoma are retained, as are in the middle ear and inner ear, otosclerosis, cholesteatoma. There's now an addition of a middle ear papilloma. The vestibular acoustic schwannoma remains. And now we see an entity that has replaced middle ear adenoma, referred to as middle ear neuroendocrine tumor, or Menet. We'll come back to that, obviously. And then lymphatic sac papillary tumor and various uncommon cancers, squamous and adenocarcinoma. So what I'd like to focus on, because it is new, and in an attempt to correlate neuroendocrine neoplasms, not only of the middle ear, but of the head and neck, to the wider category of neuroendocrine neoplasms, focus initially on middle ear neuroendocrine tumor, or Menet, which is a neoplasm arising from the middle ear mucosa with epithelial and neuroendocrine differentiation. Wide variety of names over the years, including middle ear adenoma with and without neuroendocrine, differentiation, carcinoid tumor, in the general scheme of prior nomenclature of neuroendocrine neoplasms, and neuroendocrine adenoma of the middle ear. So given this tumor's predominant neuroendocrine features, designation Menet was applied to bring or harmonize this entity as well as the larger neuroendocrine neoplasms of the head and neck relative to more common locations that we see this in the human body, including the GI tract, pancreas, and the lung. So these Menets are uncommon, but arguably are probably among the more common middle ear neoplasms. So if you deal with neuro-otologists at your university or in your practice, you see a fair amount of middle ear lesions by virtue of patients coming to that clinician. Probably you're seeing a wide variety of neoplasms, even the full extent of the classification I showed previously. Generally, because of their location, they may present as similar to chronic otitis media because of fullness in the ear or ablation of the middle ear space. There are usually hearing changes. There are conductive hearing changes and not necessarily sensorineural, as well as ringing in the ear or tinnitus. So these clinical presentations are not unique to any particular entity, can be seen across a wide variety of non-neoplastic and neoplasms, including infectious disease like chronic otitis media or even acute otitis media. Otoscopically, the tympanic membrane is typically intact. It may be perforated. A lesion may appear white behind the tympanic membrane or even in the external canal, where the differential diagnosis, if a tumor has perforated the tympanic membrane, may suggest it's arising in the external canal and may be a ceruminous adenoma. Just bear in mind that I mentioned before, ceruminal glands are seen in the external canal, usually the outer 1/3. So most of that external canal, from about 1/3 to the tympanic membrane, lack ceruminal glands. So the likelihood of an adenoma in the deeper part of the external canal is usually not a ceruminous related neoplasm. So eventually patients might get imaging and it'll delineate the extent of the tumor, may even envelop the ossicular chain, the small ossicles that provide for conductive hearing loss. So even osseous involvement in the context of the middle ear is not an indication of malignancy in any given lesion. So these get treated surgically. They usually need to be completely excised. The vast majority are indolent. They may recur, and usually that's a function of inadequate excision. Interesting, though, while many behave in a benign manner, the histology may not always be predictive. Some tumors may be aggressive and invade vital structure or even metastasize. And there's some literature to suggest that the tumors that are more aggressive in terms of local, regional, and distant metastasis may have a higher proliferation index. I don't think that really applies across the board, but at least in some articles, there's a suggestion of that. Typically, these tumors do not metastasize. But given the fact that they can be metastatic, that engendered consideration of nomenclature such as carcinoid tumor to align it with potentially what used to be considered a well-differentiated neuroendocrine carcinoma is now in the classification, as I will discuss, a G1 tumor. And most of these are G1 tumors. So at low magnification, this is what you might see. There's a wide variety of growth patterns in a given case and from case to case. Here, there's trabecular growth, maybe ribbinoid, a little bit glandular, and a little bit solid. So one image showing multiple different growth patterns. But again, if you see one of these, it may be entirely glandular, it may be predominantly trabecular or exclusively organoid. In the light microscopic features at high magnification shows fairly uniform looking nuclei. In this image here, it has that kind of salt and pepper nucleochromatin that we often think about with the full spectrum of neuroendocrine neoplasms. These are not infrequently plasmacytoid in their features, whether lining glands or in the more solid areas. Here's just a solid area of relatively bland, uniform-looking nuclei devoid of any mitotic activity or nuclear pleomorphism, and they can take on an oncocytic look. So again, you may have a tumor that's entirely one cytomorphologic feature or another tumor that can be a wide variety depending on the amount of sample tissue that you may get. Confirmation diagnostically of neuroendocrine differentiation includes keratin. Here's a CAM 5.2, may be difficult to appreciate, but there's paranuclear dot-like staining that is seen, that typifies, but it's not necessarily pathognomonic for the full spectrum of neuroendocrine tumors, synaptophysin, chromogranin, and INSM1, which is a nuclear stain, because it's a transcription factor. But because these are low grade, they usually retain the full constellation of markers of neuroendocrine differentiation detailed here. Just one aside, CD56 by itself is not diagnostic, not sensitive nor specific to neuroendocrine tumors. And, you know, I deal with a lot of thyroid. If you do CD56, it's a beautiful stain for thyroid follicular cells. So my caution is do not utilize CD56 by itself as a discriminator for a diagnosis of a neuroendocrine neoplasm. Just one mention, in the INSM1, most authorities feel that in order to call a tumor positive for INSM1, there should be at least 70 to 75% of the neoplastic cells that are positive. Short of that, it's equivocal and generally considered a non-positive stain. Interesting enough, these Menets may also express SSTR2A as well as SATB2. And this may suggest some correlation to GI tumors, as I will get to shortly. So in addition to the stains I showed you, these Menets may express CDX2 and GATA3. They're typically TTF1 negative. We don't have the full array of these hormones, and they're not necessary in the diagnosis and differential diagnosis. The images I showed you are more than sufficient. A little bit of overkill in my view, but they may express glucagon, pancreatic polypeptide, PYY, and serotonin may also be expressed. Because of the absence of myoepithelial differentiation, most studies feel that this tumor is made up of a single cell type. And because the vast majority are G1 tumors, as I will define shortly, they have a low proliferation index defined across the spectrum of neuroendocrine tumors of less than 2%. And here's just an example of a Ki67 in a case that's, essentially negative. So the origin cell type is debatable, but here's an image of middle ear mucosa. This is a Menet here, but if you look at the epithelium, it's ciliated. It's not part of the neoplasm. It's separated from, at least in this one image, but the point being is that it can be synaptophysin positive, so presumptively, and chromogranin A positive. So presumptively, the origin of these tumors, when one sees it, is from the surface epithelium. Often we don't get to appreciate this. I've seen a lot of middle ear neoplasms, and what were previously diagnosed as middle ear adenomas and now Menets, that you don't really see a surface epithelium by virtue of the sampling, or it's really attenuated. It may not be positive for any neuroendocrine markers. In addition to what I mentioned before, the biomarkers identified have been seen in the gut and classified as L cells. These L cell tumors are hindgut endocrine tumors, typically localized but not uniquely limited to the rectum. And in the scheme of GI neuroendocrine tumors, these hindgut ones are more indolent than the other tumor types. Histology is usually complex ribbons and whorls, and they express SATB2. So from a correlative standpoint, the Menets, not only histologically but biologically, simulate or are similar to the hindgut nets, and also overlap in terms of their immunohistochemical expression. This was nicely detailed by Silva Asa and colleagues in an article this last year. So Menet classification, is now grouped within the wider spectrum of neuroendocrine tumors or NETs. They tend to be locally recurrent. The term adenoma, because of the potential for metastasis, albeit low, is discouraged. Hence the moving away from middle ear adenoma with and without neuroendocrine differentiation to this classification of neuroendocrine tumors with the potential, even if limited, to possibly metastasize. As I mentioned before, they may be locally aggressive, recurrently metastatic, and in those, at least some articles, those more aggressive behaving ones have an increased Ki67 index more than 20%, which may suggest or put it into a higher grade category. So the neuroendocrine tumors, as you may know, if you deal with pancreatic and GI, are subdivided into G1, G2, and G3. In the middle ear, they're almost all G1, at least the ones I've seen, in which we apply Ki67 and counted mitoses, are really histologically low grade and don't suggest a higher grade net, although I've seen one G2 middle ear net and one G3 middle ear net that one could argue that that was a neuroendocrine carcinoma. So to date, there are no reported cases, as far as I was able to identify, of a neuroendocrine carcinoma in the middle ear. So just to go back in time to the development and evolution of the classification of neuroendocrine tumors, and I'm overlooking, 100 years of history, maybe more, prior to 1963, in the identification of Kolchitsky cells and neuroendocrine cells of the gut, and the evolution and identification of carcinoid tumors up until this point. But the first bona fide attempt to classify carcinoid tumors was this paper in Lancet in 1963, in which Williams and Sandler subdivided them in based on histologic appearance, their secretory product, and the behavioral features. So this was the initial attempt at classification. Over time, there was a spectrum identified based on cellular composition that ranged from typical carcinoid to what was called oat cell, that we now recognize as small cell neuroendocrine carcinoma. The last to be clearly identified in the literature was the so-called atypical carcinoid or moderately differentiated neuroendocrine carcinoma. But this classification scheme was widely accepted and utilized in the 1980s. And at that time, there was the advent of immunohistochemical staining, because prior to that, it was really based on morphology and electron microscopy. So with the advent of immunohistochemical staining, it buttressed not only diagnosis, but allowed for separation of the neuroendocrine tumors into typical, atypical, and small cell. Now it's applicable mostly to the lung, tubular GI tract, and the pancreas, but he evolved to other locations as well, including the head and neck, which I'm not sharing for now. But this is the first full spectrum classification of lung nets, in which the authors identified literature utilizing mitotic count and not necessarily proliferation index at this point, and subclassified neuroendocrine tumors of the lung into typical carcinoid, atypical carcinoid, large cell neuroendocrine carcinoma, and small cell neuroendocrine carcinoma. Subsequently, or maybe even contemporaneously with the evolution of lung, was the GI and pancreatic development. This is the ultimate end classification, but it also evolved from terminology previously used like carcinoid, atypical carcinoid, and neuroendocrine carcinomas. But now the NETs, or neuroendocrine tumors, were separated out from the neuroendocrine carcinomas based on mitotic activity and Ki67 indexing. And you can read this for yourself, and you're probably more familiar, or as familiar with this, as this chart shows. So that NETs were G1, G2, and G3, and there were clearly distinct and reproducible entities in these anatomic locations that allowed for extrapolating from this classification scheme and being applicable to a given tumor. The same thing for an endocrine carcinoma of small cell and large cell type, and not unique, but a rather more common location for mixed neuroendocrine and non-neuroendocrine tumors, meaning those tumors that have a combination of neuroendocrine carcinoma or neuroendocrine neoplasm that can range from a G1, G2 to G3, as well as a neuroendocrine carcinoma admixed with an adenocarcinoma or squamous cell carcinoma that are phenotypically, meaning by light microscopy, diagnostic independent of one another, confirmed by immunohistochemistry. So this is the current schema for GI and pancreatic lesions. And in 2010, David Klimster and a group of respected and well-known surgical pathologists, whether they dealt with neuroendocrine tumors or not, put this paper out. And if you're not familiar with it, I recommend that you look at it, because what it did was provide us with a reporting schema based on a constellation of features that could be applied for neuroendocrine neoplasms in general, allowing for better reproducibility and classification. And I know I'm skipping years, but it's important to get to the point in the limited time I have for this talk that ultimately led to this article by Rindi and Inzani, in which they updated the neuroendocrine neoplasm classification to suggest a more universal approach irrespective of origin of the tumor. And eventually they shared or published this paper that identified almost all anatomic sites. And there was a subsequent paper, if any given anatomic site is not listed here, it was subsequently included to apply the NETs, G1, G2, G3, and neuroendocrine carcinoma, and mean enzyme, if applicable, to almost every organ site, including the head and neck. Relative to head and neck neuroendocrine neoplasms, this is the first bona fide classification scheme. In that publication, it was 2005. Leon Barnes was the major editor, and I think he wrote this chapter as well. So at that point, the typical carcinoid, atypical carcinoid, synonymous with well-differentiated neuroendocrine carcinoma and moderately differentiated neuroendocrine carcinoma were reported. There was a small cell neuroendocrine carcinoma and paraganglioma in terms of the broader scheme of classification. And in 2005, that large cell neuroendocrine carcinoma subtype was not well established nor well accepted. So basically, a 3-schema classification for neuroendocrine neoplasms to include typical carcinoid, atypical carcinoid, and small cell. In 2017, the same nomenclature was applied, but at that point, there was comfort level in terms of literature and personal experience into identification of a bona fide large cell carcinoma with defined criteria that had been previously published by Jim Lewis, has to look neuroendocrine morphologically, 10 mitoses per 10 high power fields, with or without necrosis, but often with necrosis. Cell type was large with vesicular nuclear chromatin, and immunohistochemical confirmation. So now in 2017, the head and neck wide classification of neuroendocrine carcinomas, because carcinoid and atypical carcinoid were felt to be, well and moderately differentiated neuroendocrine carcinomas, was established to bring the head and neck in line, more or less, with other body sites. However, and appropriately so, given publications by Klimster that I showed you and Rindi, and many publications in the literature, the 2022 publication or classification of neuroendocrine neoplasms and paragangliomas, which is a distinct classification or group within the WHO 2022 publication. As I mentioned, at least in my prior talk with larynx, a lot of entities were in 2017 listed or included in anatomic specific sites. But in 2022, entities such as neuroendocrine tumors were taken away from individual sites and grouped within its own dedicated chapter. So in that chapter, the neuroendocrine tumors include NETs G1, G2, G3. We do see in the sinonasal tract on occasion pituitary lesions that may be directly involved or extending from the sella but more frequently, although it's an infrequent diagnosis, it's from remnants of Rathke's pouch in the sphenoid bone and sinus. So there really is no connection and essentially considered ectopic pituitary neuroendocrine tumors, which has replaced pituitary adenoma. So we have the neuroendocrine tumors and neuroendocrine carcinoma to include small cell, large cell, and Merkel cell, and then separate group of the paragangliomas, of which we see rather commonly in the head and neck, particularly relative to carotid body, followed by the middle ear, which is termed jugulotympanic. In limited biopsies, those middle ear paragangliomas can be squeezed and lack their distinct organoid appearance and may suggest either a non-neoplastic proliferation or something like a middle ear neuroendocrine tumor, at least morphologically. So always requires immunohistochemical staining. And in comparison to the Menets, the jugulotympanic paragangliomas will express neuroendocrine markers, but will be negative for keratins. So relative to head and neck neuroendocrine tumors, the larynx arguably is the most common site. I would argue that it's not. Just by day-to-day practice, I see a lot more neuroendocrine neoplasm, particularly neuroendocrine carcinoma in the sinonasal tract, than they do in the larynx. But according to the literature, the larynx is the most common site, followed by the sinonasal tract, followed by other sites, including the middle ear. In general, in tumors of adults, the neuroendocrine carcinomas and the nets of a G2 and even G3. Often there's a smoking history. In the larynx, these tumors are overwhelmingly localized to the supraglottic larynx. And in my first talk on the larynx, I mentioned that glottic lesions present earlier in the disease course, whereas supraglottic lesions don't, because they don't engender signs or symptoms early in the disease, so that often there are larger tumors that may be metastatic. The same applies for these neuroendocrine tumors in the supraglottic larynx. They may present as occult metastatic disease, which I'll mention briefly when I show some immunostains. But in the supraglottic larynx, by far and away, what we previously called atypical carcinoids are the most common, followed less commonly by small cell and rarely by carcinoid. And I've yet to see a case in that location of a NET G3. If we look at the sinonasal tract and salivary gland, particularly sinonasal tract, overwhelmingly the neuroendocrine carcinomas are most prevalent, usually small cell, but can be large cell. The same thing in the larynx, occasionally you can see large cell. G2 nets and G1 nets are pretty uncommon. And in the middle ear, the majority is what I talked about, the middle ear neuroendocrine tumor, and most often they're G1 and rarely G2, and almost never G3 or neuroendocrine carcinoma. So just to show you a net G2 of the larynx, here, a beautiful organoid trabecular growth, salt of pepper nucleochromin, and more nuclear pleomorphism than in the G1 net, more mitoses there too in one high power fields here. There may be necrosis. They may have amyloid, and I'll mention the importance of that later, even confirmed by Congo red, and not infrequently they're infiltrative, including perineural invasion. As is true of all neuroendocrine neoplasms, they're keratin positive, so moving left to right, keratin positive, and we have a combination A1A3 CAM 5.2 cocktail that we use consistently, synaptophysin, chromogranin, and INSM1. And you may not have as diffuse or intense immunostaining as you see here, particularly chromogranin, because these are less differentiated, but still differentiated tumors, so they tend to retain antigenicity. And not only there are increased mitoses, but there's an increased proliferation index, not quite to 20%, as might put it into a G3, but certainly more than 2%. So anywhere from more than 2 to less than 20. And interesting enough, these tumors, over 80%, are tissue calcitonin positive. So if you take a supraglottic lesion that may be small and occult and not clinically known, it may present, or there may be neck metastasis, and the lymphatic drainage of the supraglottic and larynx in general overlaps to some extent with the thyroid, and you get a lesion that looks neuroendocrine, keratin positive and neuroendocrine markers positive and calcitonin positive, the natural presumption is that it's a medullary thyroid carcinoma. But be aware that that tumor may originate in the supraglottic larynx. Certainly looking at the thyroid to see if there's a mass, but there may be a microscopic medullary carcinoma. But even microscopic medullary carcinomas tend to have elevated serum calcitonin, whereas laryngeal neuroendocrine neoplasm or neuroendocrine tumor G2, that's tissue calcitonin positive, rarely, if ever, has elevated serum calcitonin. So that may be the key discriminators. But my point being is be aware that these laryngeal tumors may be tissue calcitonin positive, may be clinically occult, and present with a neck metastasis in the lateral neck. Don't make a leap of faith that it's always medullary thyroid carcinoma. The end of the spectrum is the small cell neuroendocrine cancer. Here you can see, a submucosal lesion with trabecular growth, typical morphology, undifferentiated malignant cells, small hyperchromatic nuclei, many mitoses, tissue, individual cell necrosis, and maybe confluent necrosis, and the same immunostaining that we saw before. And I would indicate that the chromogranin here usually is very focal, strong but focal. In this particular case, it was more diffuse. High proliferation index. You don't need to worry about the mitoses. They're easily accountable. And the mitotic proliferation index is well above 20. In this image, it's nearly 100%. You should also be aware that neuroendocrine carcinomas may be HPV-related. So they may be P16 overexpressed, as you see here, and confirmed by in situ hybridization for HPV. These are typically, but not always, limited to the oropharynx. The oropharyngeal HPV-related cancers may be tiny, just like the non-neuroendocrine carcinomas that are HPV positive in the oropharynx and present as occult metastatic tumor. So these tumors may, usually of the oropharynx, if they're going to be HPV positive, originate from there, not usually of the other sites, but on occasion they may be HPV positive. But even though they're HPV positive, their biologic potential is still very aggressive, matching in HPV-independent neuroendocrine carcinomas. So what I tried to do in this talk is compare and contrast 2017 to 2020. There are added entities, benign neoplasms within that category. I wanted to focus on the middle ear adenoma or middle ear neuroendocrine carcinoma in the 2017 edition that now is termed middle ear neuroendocrine tumor, which allowed me for a wider discussion on classification of neuroendocrine neoplasms in general and those specific to the head and neck. And now there's a dedicated chapter in the 2022 to include neuroendocrine tumors, neuroendocrine carcinoma, and paragangliomas. And with that, I thank you for your attention.
Okay, welcome back. This is my second talk. We're going to talk about the update for the WHO salivary gland tumor classification. So here it is in its glory. A lot of entities to consider. Some changes which we'll highlight. Obviously, we don't have time to talk about all of these entities, nor would we want to. So a summary of changes is listed here. Some of them are very small. For example, intercalated duct has an adenoma and hyperplasia now. It is now sclerosing polycystic adenoma instead of adenosis, with the recognition that these do have activating mutations. Clear cell carcinoma is now hyalinizing clear cell carcinoma, very small change there. We've excluded oncocytic carcinoma. That was a little bit controversial, but basically there's really very little proof that this even exists and isn't just oncocytic variants of other carcinomas. We had a lot of debate about whether or not to include or exclude carcinosarcoma I have my own personal feelings about whether this is this distinct entity or not, but it stays for now. And then a few entities added, striated duct adenoma, keratocystoma, and then 2 carcinomas, which we'll talk about. Just a quick note about striated duct adenoma. This is something that is very rare and has been included for the first time. Very well circumscribed tumor with no chondromyxoid stroma, often very bloody, as you can see here. And then is comprised of these back-to-back, very pink oncocytic-looking tubules with no or little intervening stroma, and actually resembles very much thyroid or even papillary thyroid carcinoma. You can see an intranuclear inclusion there in the middle. I include this not because this is common. In fact, it's actually very rare and it's benign, so who cares? But I am looking for cases of striated duct adenoma, maybe the rarest of all salivary gland tumors. So if you have a good one, please let me know by email. Okay, so moving on, a lot of the changes have to do with this, which is very important. It's the genetic alterations that are, for the most part, defining of the various tumors. And this has had a profound impact on the way that we classify them. We don't have time, obviously, to get into all these, but we're going to pick a few examples to focus on. And so, first of all, it's not new entities, but rather variants of established salivary gland tumors. And the poster boy for this concept is mucoepidermoid carcinoma. Obviously, most of the time, 99% of the time, stains are not required, molecular is not required. It's very easy to diagnose mucoep, as is in this case. But we now realize with the advantage of having molecular testing that a tumor harboring a mammal-2 fusion is, at least for right now, defined as a mucoepidermoid carcinoma. And this has allowed us to really expand the known histologic spectrum of the tumor. So we all know about the oncocytic variant of mucoep, which can be entirely, exclusively comprised of oncocytes. A lot of the things we used to call oncocytic carcinoma are this. You can also have spindled variants of mucoepidermoid carcinoma, and then the notorious dreaded Wharton-like mucoepidermoid carcinoma, which at low power very, very closely resembles benign Wharton tumor, and for many years was misdiagnosed as such. Now we realize, again, with the help of the molecular testing guiding our histology, we realize there are subtle differences that allow us to distinguish Wharton-like mucoep from a genuine Wharton tumor, really on histology alone. There's also rare ciliated variants of mucoep, which look classic mucoepidermoid, except they harbor cilia. These tend to occur in the base of tongue and frequently metastasize to level 2 lymph nodes. We also know you can have cases with aberrant acinar differentiation. So these don't have NOR1 expression. They are not genetically acinic. They're just mucoeps having this weird acinic differentiation. And then you now get into very controversial cases like this, a very bland cyst with no proliferation, no invasion, yet happen to have found to harbor a mammal-2 fusion. And we are at a very interesting crossroads with histology and molecular. Do we regard this as a mucoepidermoid carcinoma, despite the fact that it meets no criteria, histologic criteria for it? And the answer is not yet clear. Here's another recent case I had, very bizarre, mucin-filled papillary tumor, SOX100, S100, sorry, SOX10, S100 diffusely positive, P40 negative, and yet harbored mammal-2 fusion. Is this a mucoep? Not yet clear. That mucoep is classic, but we're also getting now examples of adenoid cystic carcinoma that are genetically confirmed and yet histologically atypical. So the first one are these Sinonasal tumors that the Toronto group has described as metatypical adenoid cystic carcinoma. Can be very macrocystic with squamous differentiation, really closely resembling a myeloblastic tumor. And this goes along with a theme that we've all recognized, which is that sinonasal adenoid cystic carcinomas just look funny. So here's one that doesn't really meet criteria for any particular variant. It just looks weird. And same with this. This is a morphology I call pinky duct morphology, with these really hypereosinophilic micropapillary ducts. And yet all these weird morphologies have been confirmed to harbor MIB or MIB-L1 fusions, defining them as adenoid cystic carcinoma. So this no doubt will continue with the various named salivary gland carcinomas. So let's move on now to some entities that have really changed since the last WHO classification. The first one is intraductal carcinoma. This was in the last and previous couple of WHOs as low-grade salivary duct carcinoma or low-grade cribriform cystadenocarcinoma. It's an uncommon tumor, but increasingly recognized, typically in the parotid gland of adults. And in its pure form, which I'll explain in a moment, is almost benign, as an excellent prognosis. So classic intraductal carcinoma looks like this, tends to be very cystic at low power with areas of more solid proliferation. And all of these cysts and proliferative ducts and solid areas are entirely surrounded by an attenuated, thin, subtle layer of myoepithelial cells. So last time in the WHO was simply one entity. Now we realize there are at least 4 relatively distinct subtypes of intraductal carcinoma. The most common and most classic is the so-called intercalated duct type. It's low grade, positive for intercalated duct-like markers, and typically harbors NCOA4 RET, although you can see some of these alternate fusions, and on occasion can be fusion negative. Only rarely are these associated with conventional invasion. So here we are, classic intercalated duct-like morphology, these amphiphilic cells forming slit-like spaces, very bland. These are diffusely positive for S100 and mammoglobin, and there is some morphologic overlap with secretory carcinoma, so don't go down that pit. The second type is oncocytic. It's essentially kind of a cousin to intercalated duct-like morphology, also low grade, also positive for the same markers, though interestingly harbors most commonly TRIM33 RET, can occasionally have BRAF mutations, and on occasion the classic NCOA4 RET fusion. This one has not yet been reported to invade. Oncocytic IDC is tough because it tends to be much more solid appearing on histology with more of a subtle intraductal nature that is nicely brought out by immunostaining for myoepithelial markers. The third type, apocrine type, is the one that is really very closely related to salivary duct carcinoma and probably is an in situ form of salivary duct carcinoma. They can be low or high grade looking. They're positive for apocrine markers, negative for SOX10, S100. And genetically, they do not have fusions, but rather the same types of mutations that you see in classic salivary duct carcinoma. These often show areas of invasion, which is why we think it's sort of an in situ form. Here's a lower grade one, still with that apocrine morphology. This one's quite nasty and ugly looking, and yet you can see a retained layer of myoepithelial cells around each one of these nests. They are diffusely positive for GCDFP and androgen receptor. And here, when they invade, they look just like classic salivary duct carcinoma, no problem here. And then the last type is sort of mixed type. You can get mixed morphologies. The ones that have intercalated duct and apocrine usually have TRIM27 RET. Weird, this kind of distinctive fusion. You can have intercalated duct with oncocytic as well. Some of them have invaded. So here's one on the left is oncocytic, on the right intercalated duct morphology, and it had the oncocytic fusion TRIM33 RET. This one was a weird case. On top, you can see it's apocrine. On the bottom, it's intercalated duct, and had that classic mixed fusion, the TRIM27 RET. And there were a couple of features that we started to notice that made us doubt the conventional wisdom, which was that intraductal carcinoma was basically in situ carcinoma, not, basically colonizing pre-existing ducts. We started to notice them in very large lymph nodes, right? So if you just think about how many native myoepithelial cells would have to be in that lymph node, it really doesn't make sense. Similarly, there's a case that has been reported recurrent in bone. Again, you shouldn't have any normal native myoepithelial cells in bone. So we started to wonder, could this in fact be just a biphasic neoplasm? And in fact, we were able to demonstrate that with fusion positive intraductal carcinomas, the myoepithelial cells harbor the same fusion that the luminal cells are. So basically, the fusion positive ones are biphasic neoplasms. They are not in situ disease, and there's definitely a real question about whether intraductal carcinoma is the correct name. We left it for this time, but that's open for debate. And so that lastly brings us to this very confusing topic of conventional invasion associated with intraductal carcinoma. So occasionally you can get little foci of conventional looking irregular invasion, loss of myoepithelial cells. This case I showed you already, it recurred 3 years later as a pure salivary duct carcinoma, but that harbored the same exact fusion, the TRIM27 RET. This is a case on the left is intraductal, on the right is a kind of mucinous adenocarcinoma NOS. This had the classic NCOA4 fusion. This one, pure, nasty, clear cell high-grade carcinoma NOS that only on retrospect, it was found to have NCOA4 RET. They went back, sampled more, and found a little spot of residual intraductal carcinoma. This is a weird-looking, almost carcinosarcoma that had a fusion associated with intraductal carcinoma, but no residual intraductal component. This one was a pure salivary duct that only on fusion analysis was found to have a fusion associated with intraductal carcinoma. Here's a table from our recent paper on this concept. I know it's a lot of text, but basically showing you the broad range of invasion and outcomes that you can see in conventional invasion associated with intraductal carcinoma. So while invasion with intraductal is very easy to understand with salivary duct, it's like in situ and then invasion, it's much more ambiguous with the other types. Even the terminology is very challenging because if intraductal carcinoma is already a carcinoma, can you really say carcinoma X carcinoma? The fact that it's a biphasic neoplasm, it makes it think maybe it's related to sort of like a PA. But anyway, the terminology we've gone with is that we use frankly invasive carcinoma XIDC. Whether or not that's right, we'll have to see. The morphology is remarkably diverse. They can look like salivary duct carcinoma or low, high-grade adeno-NOS, clear cell, spindled, all these morphologies. And we also know that it can overrun the residual intraductal carcinoma component. Why is it important? Well, both RET and ALK fusions are targetable. So we want to be able to give these patients the targeted agents if we can. So I think a real argument could be made to perform fusion analysis on all high-grade adeno-NOS or salivary duct carcinomas. If you're going to do it, just be aware that the most common fusion, NCOA4 RET, is very, very easy to miss by FISH because it's a very tight inversion that looks very subtle on FISH. So if you're going to do it, probably best to do RNA sequencing to catch these. Okay, the next concept we are going to discuss are mucinous salivary gland carcinomas. So basically tumors that were mucin rich but not really fitting into a variant of anything else have been called by a lot of different names over the years. You can see them listed here. In the 2005, there was a cystadenocarcinoma and a mucinous adenocarcinoma category, but it was actually gone in the most recent, the 2017 WHO, and they were all just called adenocarcinoma NOS. And these tumors tend to be oral cavity. They tend to be very cystic, papillary. They have this kind of colonic GI-like appearance, sometimes with the dirty necrosis. Sometimes they're more solid and pleomorphic. This one almost looks more like an upper GI or pancreas cancer. And sometimes can be kind of pure signet ring or colon carcinoma. Very consistently, they've been CK7 positive, CK20, and CDX2 negative. So we collected these in a study, and yes, we found that they tend to be in very, older populations and almost always occur in the oral cavity. In our group, they were often very cystic with these kind of pushing borders, occasionally more kind of obviously colloid with tumor cells floating in mucin, and on occasion, rarely, more signet ring and morphology. The quality of the mucin in the tumors was really quite variable as well. Some pure goblet cells, some look more kind of foveolar gastric type, some more luminal mucin. So you can see it's a really wide range of tumors that we collected to study, and yet they all very consistently had this ACT1 mutation, most of which also had a TP53 mutation. So despite all the morphologic heterogeneity, they were very uniform at the molecular level. Interestingly, by behavior, most of them did very well, except the ones that had colloid and or signet ring patterns tended to metastasize to regional lymph nodes. So our proposition in this paper from last year was that mucinous adenocarcinoma is actually a distinct, although morphologically diverse entity that's all unified under the umbrella of having this ACT1 mutations. And then there's some suggestion that maybe, morphologic subtyping could help predict metastatic behavior. We'll have to see about that. And with this paper and this study, we were able to get it revived, and it is now back in the 2022. It's worth noting that our proposition is not universally agreed upon, particularly in light of this study out of Germany that described a tumor called IPMN of minor salivary glands. If you look at their paper, the tumors they describe as IPMN look virtually identical to the ones we described as mucinous adenocarcinoma, and they have the exact same ACT1 fusion. So my argument would be that these are actually just a spectrum of tumors. These happen to be relatively duct-centric and with pushing borders, very low-grade form. But I suppose it could also be argued that these are maybe non-invasive precursors of mucinous adenocarcinoma. This was a debate we went back and forth on in the WHO and were not able to fully resolve. So IPMN is not listed as an entity, but rather in sort of a, emerging entities with the suggestion that they are possibly, if not probably, related to mucinous adenocarcinoma. In my opinion, they're all the same thing. The last tumor I wanted to talk about is a brand new entity for this WHO classification. This is a tumor we described originally back in 2019 as microsecretory adenocarcinoma with a novel MEF2C SS18 fusion. At that time, we only had 5 cases, actually, none of which had any follow-up. But in the intervening couple of years, we were able to accumulate a number of cases. We had 24 in our most recent study, pretty even sex distribution with a wide age range, almost all of which, all but one, occurred in the oral cavity, with particularly the palate and the buccal mucosa being most often affected. The only one that was not oral was in the parotid gland. We were able to demonstrate the exact same MEF2C SS18 fusion with identical breakpoints in 21 out of the 24 cases. In the remaining 3, we didn't have sufficient material for RNA sequencing, but we were at least able to demonstrate SS18 rearrangement by break-apart FISH. We had treatment information in 17. All of them were managed with surgery only, and 14 had follow-up. None had recurred or metastasized. That being said, I am aware of one case proven in Europe that did metastasize to the lung. So it does appear to be a very low grade, although potentially malignant adenocarcinoma. Histologically, microsecretory adenocarcinoma tends to have a kind of circumscribed low power appearance, although on high power, you can invariably see areas of subtle infiltration into fat, skeletal muscle, or nearby minor salivary glands. They're very uniform at the kind of medium power with this microcystic growth pattern, bluish secretions growing in this fibromyxoid stroma. Very consistent morphology, although you can see there is a spectrum of the caliber of the microcysts and the cellularity of the stroma. But nevertheless, these are all the same tumor. They all have this very common appearance. At high power, again, we see the bluish secretions, very consistent, and the cells themselves tend to be very flattened with kind of minimal pink cytoplasm, these elongated, flattened, hyperchromatic nuclei with very few mitotic figures, very little atypia. Only one of the groups so far has displayed a morphology that really was beyond the typical spectrum, and that was this oral case that had a very spindled morphology. But even this one had areas of the more classic appearing features. So it allowed us to identify this tumor as a microsecretory adenocarcinoma. This tumor is very consistently S100 and SOX10 positive, and also shows the same P63 positive, P40 negative immunophenotype that you see in polymorphous adenocarcinomas. So those 4 stains can be helpful. They are negative for SMA and calponin, so they don't really seem to have a true myoepithelial differentiation, and they're consistently mammoglobin negative. So if your question is whether this is a secretory carcinoma, this helps rule. You need to point out here that there is another new entity in the current WHO that has a very similar sounding name, sclerosing microcystic adenocarcinoma. It's basically the analog to skin microcystic adnexal carcinoma. These also tend to occur in the oral cavity, but they really, despite the similar names, look very different. They're very infiltrative with this kind of cord-like, syringoma-like growth pattern, and these are actually biphasic tumors, although admittedly that biphasic nature can be difficult to demonstrate. So here's your classic sclerosing microcystic adenocarcinoma, very low cellularity overall because it has this dense fibrous stroma and the tumor cells growing as these cords or syringoma-like glands. And if you do immunostains, you see the P40 will show kind of a bilayering. The S100 is not positive in the ducts themselves, but it can show this, again, focal outer layer of cell staining. So again, looks very different than microsecretory adenocarcinoma, despite the similar sounding name. Okay, so to summarize, microsecretory adenocarcinoma is a new entity that is included in the 2022 WHO. More importantly, I think this combined approach that we use, the histology with IHC, and then finding a novel fusion, I think can serve as a model for further refining salivary gland tumor classification for the next WHO, and decreasing that number of tumors that we call adenocarcinoma NOS, maybe ultimately down to 0. And with that in mind, we are not done. We know there are still emerging, as yet unnamed, adenocarcinomas that harbor novel fusions in this adenocarcinoma NOS group. And the key will be to find a certain number of them, like we were able to with microsecretory adenocarcinoma. To that end, we have a couple of cases of this weird-looking tumor that has these kind of rosette-looking, and looks kind of neuroendocrine even, but isn't. And you can see very subtly biphasic with these kind of more neuroendocrine looking cells and very small little subtle pink ducts. We have 2 cases of this that have a novel fusion, but we need more. Same to this, I have 2 cases of this kind of very micropapillary looking, almost mucoepidermoid looking, but way too much mucin, way too micropapillary, and again has a novel. Here's another weird looking one, doesn't meet any criteria for any other tumor, so it's an NOS. And yet harbored a novel fusion. It's very spindled, with all the spindled cells being positive for cytokeratin, with scattered little bland ducts throughout the spindle cell areas. Very distinctive, and yet we don't have enough cases. And then lastly, an oral cavity tumor that has this very cystic papillary look at low power, and yet on high power it appears to be actually biphasic. So we have these kind of bluer squamoid cells, and then scattered among them are these pinker looking ductal cells. Very distinctive morphology, very unique novel fusion. So again, we know all of these tumors are distinctive tumor types. They have to be. They look different, and they harbor novel fusions. The key is, of course, going to be finding more of these, basically. And to do that, that's going to have to be a collaborative effort. These are all very rare. So we're going to have to pool our resources to ultimately get rid of this NOS category altogether one day. Just a summary of what we talked about today. There are a lot of little minor changes that we didn't spend a lot of time on. You know, hyalinizing clear cell carcinoma, sclerosing polycystic adenoma instead of adenosis. It's a neoplasm. We have intercalated duct hyperplasia and intercalated duct adenoma, as well as striated duct adenoma and keratocystoma in the benign neoplasm group. We wave goodbye to oncocytic carcinoma because we don't really think it probably exists. If it does, we find evidence for it, we'll certainly bring it back next time, I'm sure. But then we spent some time on the major changes, including the much broader spectra we realize these salivary gland carcinomas have, with the recognition of their characteristic gene fusions. It is worth noting that in the tumor definition portion of each of these chapters, when a tumor has a characteristic fusion, that's part of the definition. And so we, as I mentioned, are kind of at a crossroads. How far are we going to go down this path? I showed you some of those really weird tumors that have mammal-2 fusions. And for right now, we do have to regard those as mucoepidermoid carcinomas. So is it a molecularly defined or morphologically defined tumor type? We'll have to come to grips with that. Talked a lot about intraductal carcinoma. There's 4 different types. The apocrine type is probably salivary duct carcinoma in situ, and the other types have fusions. They're biphasic neoplasms that all have kind of different characteristic fusions and alterations. And you can rarely see conventional, what we call frankly invasive carcinomas arising from those fusion positive cases. And the terminology gets really weird, but think about that for some of your difficult to define salivary gland tumors. Might have arisen from an intraductal carcinoma. We talked about mucinous adenocarcinoma, an entity that went away and now it's back with the recognition that even though there's a broad histologic spectrum of the mucin and the growth patterns, they all seem to have this ACT1 mutation, and that probably also contains what people have called IPMN of minor salivary glands within that spectrum, although maybe it's a precursor. We'll have to do, I guess, more studies. And then we talked a lot about microcecatory adenocarcinoma and also the distinct but very similarly named sclerosing microcystic adenocarcinoma, both of which are now, for the first time, in the WHO classification. And that's all for me. So thank you very much for listening and attending this conference. Thank you. Hello.
Hey, Justin,
Hello, Bruce.
how are you?
Pretty good. I bet you're pretty tired, like me.
You betcha.
Later there.
Just an hour.
I'm just glad I calculated the time.
哦，咁但我見唔到自己嘅。Hi, Justin.
Hi.
Hey, how are you?
Great. How are you?
Good, thank you. Very informative lectures. You look slightly different from your picture.
You think I need a new picture? Yeah.
Well, you are always so updated.
Couple more gray hairs. Yeah.
You ain't close to me yet.
It's been
Hi,
pretty rapid though in the past couple years.
okay. Hi, Bruce. Thank you for joining us. Is it very late for you?
It's well past my bedtime.
Sorry about that. We're starting very soon. Okay, so we are starting in we can start now actually. 個 PowerPoint 入邊啦，咁我哋見唔到 audience 嘅。Okay. Good morning, everybody. We will, on behalf of the audience, I would like to thank our speakers, Justin and Bruce, for their excellent presentations. Now they are here with us for a real-time Q&A session, and we're particularly grateful to them because of the time zone differences. This is now their sleep time or past their sleep time already. All right, so so the insurance. Hello. Okay, so the first question is for Justin, I think. How to differentiate CAX Schneiderian papilloma and Decaf2CA?
Yeah, I mean that's a very good topic. It's kind of cutting edge, and we're dealing with it right now. I mean, it's something that we're kind of having to adjust our approach as we go on because it's a very new tumor. I guess for me, if I guess a couple things. I'm very suspicious of the notion of a non-keratinizing squamous cell carcinoma arising from an inverted papilloma. So if it's something that looks like there's inverted papilloma and non-keratinizing squame, I basically no longer believe that it's inverted papilloma anymore. And I want to prove that it isn't, the whole thing isn't a Decaf2 carcinoma. Because, you know, I think all those cases might have been, you know, under-recognized at the time. Now, if it's a keratinizing squamous cell carcinoma arising inverted papilloma, I have no issue with that. And that really doesn't overlap with Decaf2 carcinoma. And then, yeah, I guess just I'm a lot more skeptical now of an so-called inverted papilloma component than I used to be, knowing how much these overlap histologically. But it's something that's evolving, you know, like now that we know that it exists, we're still kind of exploring the boundaries. Bruce, do you have anything to add on that?
The only thing I would add is that at least the cases I've seen, the DEC-AFF carcinoma, there's no identifiable residual papilloma or mucocytes or goblet cells. So I think from a purely histomorphologic standpoint, I would expect to see some evidence or some information that the patient had a bona fide papilloma. that morphed into malignancy. But I agree, the ones that I've seen transform to malignancy are either verrucous carcinoma or keratinizing squamous cancer. I can't remember seeing one that was non-keratinizing. Maybe it's been reported, but as you said, it's evolving. But I would be, very reluctant in the face of a non-keratinizing carcinoma to invoke that it's arising in a sinonasal papilloma.
Yeah, some of these DEC tumors have areas that can be so bland. I could definitely see how they could be perceived as maybe being inverted papilloma. But Bruce, you're right. If you really, really are very strict with that and say, where is the definite inverted papilloma? Usually you can't find it if you're really strict about it. Good point. Oh, goodness.
Oh, all right, so I guess everybody can see the question.
Yeah.
I think everybody has this question.
Yeah. Well, I mean, the nice thing is at this point, Decaf2 carcinoma is not regarded as a distinct entity. It's sort of a subtype of non-keratinizing squamous cell carcinoma, as is HPV-related, carcinoma. So you're not at this time obligated to go any further if you cannot. In fact, what I usually do, because FISH takes, a week or something to get back, I'll sign these out as non-keratinizing squames and I'll report the DEC studies as an addendum, because they're still non-keratinizing squamous cell carcinomas. But I mean, it may be in the future that they are regarded as their own distinct entity, and then we'll have to figure out how to deal with that. I mean, this AF2 IHC might be promising. If that is as good as NUT protein in diagnosing NUT carcinoma, then we may be in good shape and be able to diagnose it rather easily without having to do molecular testing. But I think for now you're okay.
Yeah. So the way out is to wait for the commercial antibody, I guess, right?
Yeah. Fingers crossed that it's a good one, because the nut is wonderful. It's actually, in my opinion, better than FISH because it picks up things that can be missed, like NOR1 and actinic cell carcinoma. There's some proteins that are really, really good. So yeah, I hope AP2 is one, because I do think it's unique and probably should be eventually regarded as its own thing. The other one I guess I would add is adamantinoma like Ewing, since that can look so much like non-keratinizing squamous cell. I do routinely address that as well when I'm dealing with these, but that can be addressed pretty simply, ruled out with a CD99, because non-keratinizing squames are negative. So most people have access to CD99.
Okay, still for Justin, the next questions about teratocarcinosarcoma, how to differentiate it with the sarcoma with heterologous tumor component.
From a sarcoma with a okay, so like if a teratocarcinosarcoma had a rhabdomyoblastic component, how to differentiate it from a rhabdomyosarcoma with some aberrant epithelium or something? Okay. Well, I mean, really, traditionally, we wanted to see every single tumor component to call teratocarcinosarcoma. And for that reason, I mean, at least in my experience, it was incredibly rare to make that diagnosis, 10 years ago, just because it was rare to see all those elements really well developed, I would say with the kind of use of SMARCA4, that has really allowed me to diagnose this with more confidence. So I guess I'm not saying that that has to be seen, but just, most of them have SMARCA4 loss. And so that helps. And then, I mean, I don't know, a sarcoma with, well-developed neuroendocrine component and fetal type epithelium is just not something that you really see. Bruce, do you?
Yeah, no, I totally agree. If you have all the elements of a teratocarcinosarcoma, particularly the fetal type epithelium and the neuroendocrine, that'll help you distinguish between the two.
Have you been seeing more teratocarcinosarcomas lately too? I was just talking to somebody about this the other day about, I mean, it was the rarest of rare, and now it's like, well, I mean, they're still uncommon, but it just seems like, and I assume that just means we're better at recognizing them.
or yeah, and they don't get sent for consultation.
Maybe so. Yeah.
Okay, Justin, this is your favorite area, sinonasal. How to differentiate metastatic colorectal adenocarcinoma and a sinonasal intestinal carcinoma?
There's really nothing from the pathologic point of view that I'm aware of. All the intestinal markers are positive in these. So it's really clinical radiologic grounds. I know that's not a very rewarding answer, but it's the truth.
Okay. All right, Bruce. Should HPV testing be done reflexively in intraepithelial lesions of the larynx?
In my opinion, no. The laryngeal ones overwhelmingly are unrelated to high-risk HPV.
Yeah.
And therefore, the utility of doing any testing, although I'm not sure what it's like outside the US, but there's a lot of pressure from clinicians who don't understand the use of P16 to reflexively ask us to do it. And we try to educate them to make them understand. But I must admit, I've seen at least 2 cases in young 20-year-olds that were conventional squamous cancer with intraepithelial dysplasia that the clinician asked me to do a P16, and it proved to be positive. And to prove it, we did in situ because P16 overexpression is not necessarily related to virus, and they were HPV positive. So, there are unusual circumstances, but to answer the question specifically, no, I don't recommend reflexively doing any kind of testing. If I did, I'd start with P16.
Okay.
If it's diffusely positive, I would need to prove it with in situ hybridization.
Okay, thank you. The next question is the terminology of NETs grade 3 and NETs overlapping.
The terminology, no. Well, first of all, a NET G3 in the head and neck is extremely rare. So to try to apply it there is a little bit problematic, but in more common sites, like the pancreas and the GI tract, there is a clear differentiation between what a NET G3 is morphologically and neuroendocrine carcinoma, whether small cell or large cell. So are they overlapping terminology? No, they're distinct with a different prognosis. Therapy may be the same, but the NET G3s, although the worst of the NET in terms of prognosis, has a much better prognosis than either small cell or large cell neuroendocrine carcinoma.
I think this applies to basically all organ systems, the same terminology. Yes. So these are basically the same differentiation between a grade 3 NET and carcinoma. Okay, another question. In view of the changing classification and grading system of dysplasia, how should pathologists explain the implications to clinicians, especially for consultation cases?
The implications of the changing classification and grading. I think the best advice I would give is be consistent with whatever classification grading system you're using day to day, so that our clinical colleagues, the ones that you deal with, specifically understand exactly what you're trying to convey. And the implications, therefore, are applicable to what your terminology is and what your diagnoses are. So, it's too broad a question to extrapolate for everybody. So I think we all need to be specific with our clinical colleagues, because ultimately that's who we're providing the diagnosis with. So whatever terminology you use, and I'm not necessarily advocating one, a 3-tiered system or a 2-tiered system, although I like the 2-tiered system. Our clinicians need to understand what we're talking about.
Yeah, I think this is now basically replacing the 2-tier system is now basically used all over different systems as well. Bruce, there's also a question that's the audience has. It's one of the pictures that you show. This one. So I guess people need.
I think if you just go by what's written in the book,
yeah,
then you'd be stuck with a lower third. But what you're not showing is a previous image that cancer dropped off from that dysplasia. So this is where consensus has been problematic, because if you only use the definition, then you're stuck with, it's the lower third. But the degree of dysplasia and the elongated reedy ridges, particularly in the upper airway, the oral cavity and the larynx, is notoriously bad. And this will progress to invasive carcinoma in percentages much more significant than what might be considered low-grade dysplasia. So by experience and having viewed a lot of cases and being taught by individuals who had, more experience than I did, this to me has gone over anything that could be low-grade and will progress to invasive carcinoma. I'm not sure that's a great answer, but that's the problem with, upper airway differentiator or keratinizing dysplastic lesions.
Yeah, that's nasty.
Okay, thank you. Justin, there's a question for you. HPV-related multiphenotypic sinonasal carcinoma. As the tumor may present areas of adenocystic carcinoma pattern, and the immunostaining may not be very telling. So how can this be differentiated from conventional adenocystic carcinoma?
Well, harboring high-risk HPV is the simplest answer. True adenoid cystic carcinoma never does. This tumor does by definition. The majority of cases will also show areas of squamous dysplasia that looks pretty weird and high-grade looking. Not always, but often. And so those two things are very helpful. And quite frankly, most of these multiphenotypics, they look weird. The cases that look like a regular adenoid cystic carcinoma, I mean, one or two, maybe. I think, Bruce, you saw one that was really adenoid cystic-like. But for the most part, they look odd. They've got weird spindling and bizarre anaplastic giant cells, and they're just funny looking. So that's another kind of clue that that's what you may be dealing with. Be careful about just using P16 alone in this setting, I should say. It's okay as a screen, but if it's diffusely positive for P16, you got to follow it up with a more specific test, because, adenoid cystic carcinoma can be pretty positive for P16 too. And that's a mistake you don't want to make. You don't want to accidentally call adenoid cystic HPV-related multiphenotypic, because you're telling them that it's going to have a pretty good prognosis when it won't. So I'm glad we were able to get that codified in the latest WHO.
Okay, this is a quick question for Justin. It's actually available for Memo 2.
Not that I'm aware of.
Are you aware of that?
I want to ask Bruce this. There's an old picture in one of the old WHOs, like 2005 or something, of a mammal 2 stain. And I don't know where it came from. I don't know whose it was. And certainly there's nothing available, commercially. So what was that about?
I have no idea. I have to go look at that. I think it's a typo. It's a typographic error.
I remember seeing that and I was like, wow, this is going to be great. This is going to be a game changer. And it never materialized. So the short answer is no, there's not. Unfortunately, that'd be great if we had a good marker. And I don't know if I'm not an IHC guy. So I don't know if that's like, a reasonable target to try. I've been thinking about RNA-ish, if that could work for a more rapid kind of microscope-based test. But as of right now, there's neither commercially available.
So I have one more question for each of you. Justin, how do you differentiate olfactory neuroblastoma and neuroendocrine carcinoma? IHC useful?
Well, like a high-grade olfactory neuroblastoma, that can be challenging. And, you know, assuming that a lot of the things we used to call high-grade olfactory neuroblastoma may not be in retrospect, but it does exist. And so, I mean, the keratin expression, how much is too much for an olfactory neuroblastoma is a really open question, especially now with the concept of olfactory carcinoma. Traditionally, we would use things like sustentacular S100, even if it's a little bit in focal, as it often is in high grades. If you see any kind of, you know, fibrillary stroma, that would push you more towards olfactory. But I'd say at this point, you know, the extent of keratin is probably the most helpful in separating a high-grade olfactory neuroblastoma from a neuroendocrine carcinoma, including olfactory carcinoma.
Thank you. Bruce, last question for you. Is there any minimum size criteria for head and neck NETs and anything regarding microcarcinoids in head and neck sites?
As far as I know, there's no minimum size criteria for any of the nets. And I'm not aware of any microcarcinoid. One could argue about the thyroid, but aside from the thyroid, and even there, it's I would question that because it would be a micromedullary carcinoma. But anywhere else, I'm not aware of. Are you, Justin?
No.
Yeah.
Okay, thank you. That's very clear. And the time is running out. And
Oh, let's do more questions. We're up.
And if you are game, I'll forward the questions to you, and you can email back to us, so we pass back to the audience at a later date. Thank you very much, Justin and Bruce. And I know it's treading into your sleeping time. It's really very late for you, and thank you very much for staying late for us. And we are all very appreciative of your excellent lectures and the interaction with you.
My
So
pleasure.
Thanks for the invitation.
hopefully we'll meet in person very soon. Thank you very much.
Bye. Good to see you.
Yeah, Justin. Good night, everybody.
Bye.
Thank you. Bye. Hold your hand.
It's my pleasure again to continue the presentations of the new World Health Organization classification of head and neck tumors from the 5th edition. And as you can tell, I'm going to cover a bit of a potpourri of the various entities within this anatomic site of oral cavity, oropharynx, odontogenic, melanoma, germ cell tumors, metastases, and tumor syndromes. Again, I do have royalties from books, and as a compliance disclosure, I'm both a standing member of the editorial board for the WHO as well as an expert member for this particular book. So let's talk about the oral cavity for a few moments. As you can tell from the 2005 edition, there were 58 different diagnoses that were included. That has been now reduced for the 2017 to 26, and now down to 16 diagnoses for this edition. Much of this, as you know, is related to the fact that duplication for soft tissue, bone, hematolymphoid lesions have been taken out, and therefore this creates a much more easy overall approach. The new entities for this particular edition are actually the non-neoplastic ones. So when one thinks about the tumor-like lesions or reactions that can be seen, necrotizing salometaplasia, multifocal epithelial hyperplasia or Hex disease, as well as oral melanoacanthoma, are all lesions that can simulate neoplasms and therefore were included for the sake of completeness. There have been some changes in the oral potentially malignant disorders and the oral epithelial dysplasia entities, specifically as it relates to architecture and cytology. And then, of course, submucosal fibrosis, HPV-associated dysplasia, verrucous carcinoma, and carcinoma cuniculatum all had significant changes for this edition, and the update for ectomesenchymal chondromyxoid tumor, specifically as it relates to the now recognized gene fusion. So let's start out with oral melanoacanthoma. This is a non-neoplastic process, but it's characterized by this proliferation of both the epithelium as well as dendritic melanocytes that has a very, very rapid clinical onset, even though it is an indolent behavior. And so here you can see such a lesion immediately adjacent to the tooth as it goes into the gingiva. And it is a remarkable increase in rapid size over a very short time. There's usually a dendritic melanocytic proliferation that extends all the way up into the upper reaches of the epithelium that is associated with some spongiosis as well. But of course, there is no nested pattern, there's no atypia, and of course, it does not extend down into the underlying stromal component either. Usually there's some sort of deposition of melanin present at the basal layer, as you can see in the histology image. Submucous fibrosis is a chronic and insidious disease characterized by this progressive deposition of fibrous connective tissue in the submucosal tissues of the oral cavity and oropharynx that has a risk of transformation to squamous cell carcinoma. So you can tell here in the oral cavity, there are clearly other things going on as well, since there's frequently tobacco use, betel nut chewing, etc., that is also seen concurrently with submucous fibrosis. The early changes tend to have a very minimal increase in vascularity, inflammatory infiltrate, and some fibrillar collagen, while later on it becomes a bit more homogeneous, starting immediately underneath the epithelium, as you can see highlighted by the arrow in the lower panel. As it advances, it finally gets to a complete loss of vascularity with hyalinized collagen deposition and dense fibrous connective tissue. So this is one of the new entities that is associated with an increased risk of the development of squamous cell carcinoma. As you know, the HPV-associated dysplasia is a very characteristic histologic appearance in the oral cavity, not in the oropharynx, where there's a karyorrhexis or dyskeratotic appearance to many of the cells, where the entire thickness of the epithelium is completely disorganized and lacking maturation as it goes to the surface. And of course, this has a very strong association with HPV, whether documented by P16 or one of the in situ hybridization methods to high-risk HPV. So it is a very specific finding. This is not recommended, again, that every single dysplastic lesion of the oral cavity have a P16 or high-risk HPV tested, but it is in this very specific and unique setting in which that additional testing can be performed. Verrucous carcinoma and carcinoma cuniculatum both had a significant increase in improvement in the nomenclature for them and the classification of them. And I can tell you that carcinoma cuniculatum, when you look at it like this on low power and a resection specimen, is absolutely fantastic and classical, because you can see all of these burrows and furrows, if you want to call of them. Rabbit warren is sometimes used as the colloquial description for this, where you can see that there is this very, very convoluted overall appearance. However, I can tell you that in general, you're going to get a biopsy that comes through just this superficial surface over here, and it may look like pseudoepitheliomatous hyperplasia or an atypical squamoproliferative lesion that doesn't otherwise allow you to reach the correct interpretation. So just be aware that many times carcinoma corniculatum is one of those cases where the clinical pathologic correlation between what is being seen clinically and what you're receiving histologically must be done in order to be able to address the diagnosis correctly. So this is an idealized case. And I know when Susan Mueller was submitting it, she was like, oh, this is the best case I've ever had of this particular diagnosis. And it really is quite classic for the lesion. In the oropharynx, as you know, in the 2005 edition, nothing was included at all. So it was still part of the oral cavity in that setting. And yet in the 2017 fourth edition, 11 diagnoses were given in that site, and it was separated out from the oral cavity. And now we've gone down to just 3 diagnoses, specifically as it relates to the hamartomatous polyps or lymphangiomatous polyps as one of the benign reactive or hamartomatous lesions, and then updating the entities of HPV-associated squamous cell carcinoma versus HPV-independent squamous cell carcinoma. So initially, the term HPV-unrelated had been used, and that just sounded very awkward, but HPV-independent is now the classification used for this tumor entity. So if you think about hamartomatous polyps, again, these are lesions that are associated with a palatine tonsil, specifically a haphazard proliferation of elements that are normally found in the oropharynx and associated with a lymphangiomatous appearance, which is the #1 group of this particular lesion. There are multiple different lesion types that can give you hamartomatous polyps, but the lymphangiomatous one is the most frequently seen. Generally, younger age at initial presentation without any sex difference. So I think you can tell from the histology down in the lower corner here that there's an abundant lymphoid infiltrate with these very dilated vascular channels that are part of the lymphangiomatous appearance for this lesion. This is just an example of normal tonsillar epithelium, and I bring it up specifically to be able to say, I would like one of you to tell me where the tonsillar epithelium begins and where it ends and where the lymphoid component starts and stops. And you can tell it is an incredibly intimate relationship. Here is another area of a different case, just to highlight again that there is no evidence of a basement membrane. And it is for this reason that the idea and concept of an in situ lesion for oropharynx is kind of negated, because you can't ever really tell when it has invaded beyond the basement membrane when there is not one. So here is an example of a tonsillar resection. I'm actually going to drive this case for you, and I hope that you'll be able to see it here. And I think that you can tell from this area that, you know, there is normal tonsillar epithelium. It has a very nice lymphoid component. The epithelial elements, as you see them over here, have that same, you know, juxtaposition of the lymphoid and epithelial component immediately adjacent one to another. And so you may say, where is actually the tumor in this? And lo and behold, if this is not the tumor here. Now, what I'd like to do, because, you know, we can do this with the measurement tool, is if I measure from there to there as the overall dimension of this lesion, you can see that, in fact, this tumor is less than 2.5 millimeters as a total diameter for it. I'll go up to higher power just so you can see the architectural features of this, but this is merely to highlight that this is the type of tumor that actually presented with evidence of lymph node disease, and therefore it is often very, very difficult to be able to highlight the primary tumor in the oropharynx when you're looking at it radiographically. Here is an example of such a lesion deep in the tonsillar crypts and in the deep lymphoepithelium. And in fact, when you do a P16, you can see how the neoplastic cells are strongly and diffusely reactive, with greater than 70% of the nuclei and cytoplasm giving you a strong block-like reactivity, while the overlying surface epithelium is completely uninvolved in this example. So as I already suggested in the previous lecture, there are these very fantastic data sets that are utilized for them that allow for a standardized reporting by the International Collaboration on Cancer Reporting, or ICCR. And with that, there are accompanying explanations and recommendations of the guidelines. These have been published in the Archives of Pathology and Lab Medicine for the entire data set group. And so when you look at the histology reporting guide, you can tell that there's a very standardized approach to what information is being reported, such that from each different organization or even across geographic areas, you're able to now come up with the exact same terminology. Likewise, the WHO classification system has been reproduced in these so that they match exactly what is going on with the new classification of the book. I think it is important to mention that HPV-associated neuroendocrine carcinoma is one of the entities specifically recognized as a tumor subtype. As you will see here, there's a very strong synaptophysin reactivity in the neoplastic cells that are also strongly and diffusely reactive with P16. And I'm going to talk about this a little bit more later on, but I think you're well aware that the HPV-associated finding in the oral pharynx is certainly something that can be seen with neuroendocrine carcinomas. So let's put our love aside for oropharyngeal lesions and go on to the next category, which is the odontogenic and maxillofacial. You can tell that the number of entities keeps expanding every year as we go through the various editions, and now we're up to 55 different diagnoses. So this is clearly one of the larger chapters in the overall book. Some of the new entities were the odontogenic cysts related to surgical ciliated cysts. Adenoid ameloblastoma was one of the epithelial odontogenic lesions added. And then there was a significant change in the fibroosseous lesion dysplasia category as to how they were going to be classified and in which section they were going to be placed. One of the new entities was included as a malignant jaw tumor with the TFCP2 rearranged rhabdomyosarcoma, which I'm going to discuss in a little bit more detail. Again, melanotic neuroectodermal tumor of infancy, osteoid osteoma, and plasmacytoma were all moved into their respective categories elsewhere in the book. And then there was a significant reorganization with the concept of going from benign to malignant within all of the various categories of odontogenic carcinomas and osteosarcomas, chondrosarcomas, etc. So when you think about it, the book has also had the ability to have several tables added. Here is an example of such a table just talking about what the radiographic findings are for these various lesions, separated out by their most common age at initial presentation based on decades of life. And you can see that there really is quite a remarkable variation of whether they are radiolucent, mixed radiolucent and radio-opaque, or whether they are just radio-opaque. Likewise, within this, some of the genetic pathways have been identified for a variety of different odontogenic lesions. Here you can see the giant cell lesions separated out by decade. So in other words, which decade are they the most commonly identified with and which gene has been seen most frequently within it. Likewise, the same thing has happened with the fibroosseous lesion category, where each of the various diagnostic entities has been separated out based on which genetic abnormality has been seen within them, or at least identified thus far. And finally, between the bone and cartilaginous tumors, whether the benign lesions or the malignant lesions, you can tell which of the various molecular pathways have been identified, or the specific gene or mutation has been documented, and allows for a very easy way to look at how there is some remarkable overlap between these particular entities. So these type of graphs are very helpful within the book in order to be able to give a better classification system. So let's talk about surgical ciliated cyst. It's actually just an implantation phenomenon, if you will, where the person has some traumatic event related to either surgery or trauma, and there's a displacement of respiratory type epithelium, usually showing this very well demarcated appearance radiographically. And then of course it's lined by just normal respiratory type epithelium, and therefore goblet cells are quite frequently identified in this lesion. The adenoid ameloblastoma is a new example of an ameloblastoma category where it's partly cribriform in its architectural arrangement, showing some reverse polarization, with only a very minor component of stellate reticulum being able to be identified. The basal cells very frequently are multi-layered, transitioning to a round or ovoid morphology with some duct-like structures present. And of course, about 2/3 of the cases will have some appearance of dentinoid type material within them. Segmental odontomaxillary dysplasia has been included as well because this is a non-hereditary but still unilateral developmental disorder characterized by both maxillary bone as well as soft tissue involvement by a homolateral cutaneous manifestation seen in some of the cases as well. So radiographically, there's usually a periapical or poorly defined area of abnormal bone, as you can see in this radiograph, representing what is seen in the patient above, where there is an overgrowth of these soft tissue related elements. Very rarely is a sample taken, but when it does, the bone biopsies will reveal some irregular bone spicules and, of course, accentuated reversal lines in the bone. This is, again, an entity that is included because of its tumor-like presentation, both radiographically as well as clinically. I think this is one of the most significant additions is the TFCP2 rearranged rhabdomyosarcoma. As you know, it's a high-grade rhabdomyosarcoma showing a spindle cell morphology most regularly, with the majority of the patients being young at initial presentation. And because they arise within the bone especially, and the craniofacial bones specifically with the mandible, maxilla, and skull bones is why it's being presented in this chapter. There's often a biphasic appearance with the spindle to epithelioid areas, but it is also important to recognize that pure types can be seen of either pure spindle or pure epithelioid type appearance. Very monotonous, conspicuous nucleoli, usually mitotic activity and tumor necrosis, and then it has an unusual immunophenotype of expressing both epithelial markers such as AE1, AE3, along with desmin, myogenin, and MyoD1, with the MyoD1 much more strongly positive. And then finally, ALK is also presented. So you can tell that if you're just doing a very narrow focused immunohistochemical panel, you're likely to get the wrong diagnosis unless you expand it to include several other lesions within the diagnostic category. Here is such an example where you can see the surface epithelium overlying is not dysplastic, and that's one of the key features, because I think it is difficult to tell where the surface epithelium ends and the underlying spindle cell morphology appears. When you look at it on high power, you can see that there is a plasmacytoid to epithelioid type appearance, but still showing a spindle cell morphology with easily identified mitotic figures, including atypical forms, as you can see in the center over here. By immunophenotype, as I've already suggested, it has this cross-reactivity between epithelial markers such as AE1, AE3, with the myogenin, MyoD1, as well as ALK being expressed in the tumor. So an important consideration, especially in a young person with a spindle cell lesion, we used to always say squamous cell carcinoma, squamous cell carcinoma, squamous cell carcinoma, but now we also need to include the TFCP2 rearranged rhabdomyosarcoma category. Mucosal melanoma went from 6 different diagnoses to 3 in the 2017, and now is just 1 diagnosis because basically it's saying it can occur anywhere within the upper aerodigestive tract. About 20% of skin melanomas occur in the head and neck, but about 4% of them are mucosal in this location. So sunlight is a presumed non-factor. People will lie out in the sun and you can tell that the nose may be affected, sometimes even going into tanning booths, the UV exposure may be there. But in general, this is considered to be not a factor, with formalin exposure much more likely to be the case, especially in yourself as a person involved in the lab or being a pathologist. Radiation and geographic location of residence can also play a factor. The mucosal melanoma is equal in the sexes, quite different from what you see in the cutaneous counterparts, and they also present at an older age at initial presentation, with the oral cavity and nasal cavity much more likely affected. They tend to be somewhat sizable, in other words, 2 to 3 centimeters in overall dimension. Most of these polypoid lesions, sometimes there's a dark tumor to represent that there is melanin present within it. Surface ulceration is quite common. And because of the fragmentation, Breslow's thickness or Clark's level cannot be meaningfully determined or measured, and therefore just are not included in this area. So you will notice a MRI showing a very large destructive lesion, endoscopy view of a large polypoid mass affecting the nasal cavity. And on the gross inspection, you can tell that it is a darkly pigmented lesion affecting the septum, and in fact is also destroying the cartilage of the adjacent septum. So if junctional activity or pagetoid spread is seen, it can kind of help to define the presence of a primary tumor, but just remember that stromal involvement alone is also quite commonly seen in this particular category. Very, very wide histologic spectrum. We always use the term protean for this, and so I've included an example of Proteus, the god of change, as he can present in any particular form he chooses. And with that in mind, you can have a variety of different patterns. from the peritheliomatous and epithelioid to solid fascicular storiform papillary alveolar. Really, there's anything, as well as a variety of different cytomorphologic appearances, ranging from round cell to spindled, polygonal, giant cell, etc. If you do have involvement of the surface epithelium, here you can see multiple areas of pagetoid spread of the tumor as it has gone into the overlying surface. Here's an example of just a single highly atypical melanocyte present at the junction, and there is overlying squamous metaplasia in this example. Clearly, pigment is easily identified in this case, and so it would not be so challenging to come up with a diagnosis. But a spindle cell lesion such as this would probably be much more challenging to be able to reach a correct diagnostic interpretation. The small blue round cell category of neoplasm is brought to mind with this example of a melanoma, where it has a completely round cell morphology. Peritheliomatous distribution, where it wraps around the vessels and remains viable, another example here of a spindle cell tumor showing that same phenomenon, can be a helpful tip-off to the underlying diagnosis that is present. However, the spindle cell morphology in fascicles seen here with a very prominent nucleolus seen in these examples can certainly suggest that a melanoma is present, but it is by no means specific for the diagnosis. As you know, there are a variety of different melanocytic markers, with SOX10 and S100 protein perhaps utilized most regularly, while HMB45, tyrosinase, melan-A, and even PRAME as the newest marker can certainly be utilized in this. Just be aware that there is usually remarkable phenotypic infidelity or anomalous immunoreactivity that can be seen in this tumor category. Within the mucosal site areas, NRAS and KIT mutations are much more frequently seen than the BRAF, and so this is quite different from those that can be seen in cutaneous anatomic sites. So here is an example of the SOX10. You can see a very strong and diffuse reaction in this round cell morphology, and S100 showing spindle cell melanoma positive in both the nucleus and the cytoplasm, while HMB45 and even melan-A can be expressed in these tumors. The new marker of PRAME gives you a very strong nuclear reaction in melanocytes. However, there are some other tumor categories that can also be positive. So even already, this is not quite as specific as it was originally thought to be. Germ cell tumors in the head and neck actually were aggregated into a single location, basically considering teratoma to be a benign lesion arising from all three germ cell layers, while the extragonadal malignant germ cell tumor category encompasses really any of the spectrum of tumors that can be seen in the gonads. So specifically for the malignant germ cell tumors, yolk sac tumor is by far and away the most common, but it is also important to recognize that SMARCB1 or SMARCA4 deficient carcinomas and even teratocarcinosarcoma can be seen with various components that can mimic yolk sac tumor. So it is important to exclude those particular entities. And then, of course, also excluding that it does not represent metastatic disease is a significant observation. When one considers metastases to the head and neck, I think this is a very important thing to consider as well. It was not included at all in the 2017, but now is under one diagnostic chapter, which really just says they must be tumors that have arisen elsewhere and have resulted by either lymphatic or vascular spread into one of the lymph nodes or soft tissues bone of the area. So they are divided into anatomic site. And as you can tell, one of the tables there, and I'll show you this in a two-part slide here, divided by anatomic site with the most common metastatic malignancies identified and what relevant immunohistochemical markers can be performed in order to make a separation between them. And you can tell this is a very extensive documentation of the most common and frequently seen of the tumors, and allowing you to be able to come up with a meaningful separation between them. Recognizing, of course, that always it can be that lineage infidelity or immunophenotypic overlap can be seen within any of these lesions and therefore should not just be relied upon on its own. So here is an example of a metastatic prostate carcinoma, giving you a very non-specific glandular appearance. But of course, here the NKX 3.1 is strongly positive, and an example here of an oxophilic pattern to a renal cell carcinoma, showing a very nice PAX8 immunoreactivity in this case. So clearly immuno can be utilized in order to be able to reach the correct interpretation of these lesions. Finally, I'd like to end with the genetic tumor syndromes, and you can see that a couple were presented in 2005 with one lesion presented in the 2017 edition, but this is the first time that there has been a chapter devoted specifically to the entire group of genetic tumor syndromes in which the head and neck has the major manifestations. So it's trying to establish associated findings and disorders, giving recommendations for how to monitor as well as how to treat these particular lesions, while giving very specific presentation of careful family documentation, DNA sequencing aids in order to be able to reach the classification, and recognizing that sporadic tumors are becoming less and less, and more likely they are part of a syndrome association. And this, I think, is a meaningful representation. Just to let you know, there will, in fact, be a familial tumor syndromes book that is going to come out as the final entity within the 5th series, where an entire tumor classification will be presented in that fashion. So just as a single example, of course, all of us are familiar with Gorlin syndrome or the nevoid basal cell carcinoma syndrome, originally described actually in 1894 and then recognized as an entity in 1959 as an autosomal dominant associated specifically with the sonic hedgehog pathway. So what has been attempted is the major criteria are listed, minor criteria are presented, both histologically as well as clinically, and then what the parameters are that need to be documented in order to reach an actual interpretation. So here you can see a young child with innumerable basal cell carcinomas affecting the face and chest, the palmar and plantar pitting that is so characteristic of the lesion, presentation of a medulloblastoma on the left-hand side, and calcification of the falx on the right. And then, of course, within the head and neck area for this multifocal or multiple odontogenic keratosis, as you can see diagrammatically represented, and then showing multiple lesions in the panoramic view. Classical appearance of the odontogenic keratosis with areas of subepithelial clefting, basal palisade, and the hyperrefractile area of perikeratin that is seen at the surface, and also recognizing that these daughter cysts that can be seen present in the deep stroma are one of the most characteristic findings when one sees evidence of a syndrome association. So with that, I would like to end and thank you very much for listening to this particular presentation of some of the updates from the World Health Organization classification of tumors. I'm going to continue the presentations of the new World Health Organization classification of head and neck tumors for our 5th edition, and specifically as it relates to the soft tissue and hematolymphoid lesions. Again, I do receive book royalties, and as a compliance disclosure, I'm a standing member of the Editorial World Health Organization board, as well as an expert member for this particular edition. So let's talk about the soft tissue related tumors specifically. And in this example, there were 44 diagnoses in 2005, 32 in the 2017 edition, and we've remained the same now, although there has certainly been some consolidation, as well as the introduction of some new entities. So specifically, except for site-specific lesions, all of the soft tissue tumors have been aggregated into a single chapter and then divided by various histogenic groups. Most importantly, things like, glomerulonephrocytoma or biphenotypic sinonasal sarcoma, even sialolipoma, when they are very specific to that anatomic site, have been kept within the anatomy rather than being incorporated into the main overarching group. New entities included in this book include the EBV-associated smooth muscle tumor, the phosphaturic mesenchymal tumors, extraskeletal myxoid chondrosarc, as well as the Gli-altered soft tissue tumors. There have been new names that have been applied to previous entities as well, like epithelioid hemangioma, formerly known as angiolymphoid hyperplasia with eosinophilia. The rhabdomyosarcoma category specifically has been presented as one group in here, with the exception of the specific fusion-related lesion in the bone chapter, but otherwise not separated out into each of the same classifications was seen in the soft tissue book. And then, of course, Ewing sarcoma has been significantly updated especially as it relates to the adamantinoma-like Ewing sarcoma, which I will talk about here in a few moments. So the EBV-associated smooth muscle tumor is a lesion that must have EBV infection and usually in the setting of immunocompromise. By far and away, the vast majority of these develop in the larynx, although they can be seen in the oropharynx as well as in the orbit. The vast majority of the patients have some sort of transplantation history, and it is usually a renal transplant, although it can certainly be others as well. But things like HIV infection, malnutrition, or other events that may cause immunodeficiency have also been documented to be associated with the development of the lesion. Histologically, one of the interesting things about this is it's an interlacing fascicles of spindle to smooth muscle cells with ample cytoplasm. However, sometimes an epithelioid compartment of cells with a very open chromatin and a box-shaped oval nucleus can be seen as well, so giving almost a round cell morphology in some areas. Nuclear atypia can be seen, and of course, increased mitotic activity can also be easily documented, and it tends not to be associated with evidence of necrosis unless it is associated with an HIV-infected patient. All of the immunomarkers that you would expect to be seen in a smooth muscle tumor will also be positive here with smooth muscle actin, cal-desmin, desmin and SMMHC, or smooth muscle myosin heavy chain can also be seen. By definition, EBER must be positive, usually by an in situ hybridization technique. So here is an example in the larynx, an intact overlying squamous epithelium with this very small blue round cell or epithelioid type appearance to it. Very, very well-developed open vesicular nuclear chromatin. And in fact, you can see that there are several mitotic figures in this high power field as well. They are positive, as I already suggested, with a variety of markers, including desmin shown here, while definitionally showing an EBV positive reaction in the nucleus of the neoplastic cells. So a new entity for this particular book. The phosphaturic mesenchymal tumor has also been incorporated in this edition as a distinctive neoplasm that is associated with tumor-induced osteomalacia, usually through the production of fibroblastic growth factor 23. And there has to be a clinical pathologic correlation in order to reach the diagnosis. So there must be clinical evidence of phosphate wasting and or osteomalacia that generally is removed with a complete removal of the tumor, and sometimes the FGF23 levels can be identified as being elevated in the serum. Many of these lesions develop in the head and neck, and in fact, it is the second most common location for the tumor, with about 50% affecting the paranasal sinuses. There tends to be a very bland ovoid spindle to stellate morphology and a very richly vascularized stroma, but the pathognomonic basophilic or smudgy matrix material kind of gives you a grungy or flocculent calcification within the background stromal component. Sometimes adipocytes can be seen, prominent thick-walled vessels can also be seen, kind of a myoid appearance to them. And it is interesting to note that many of the head and neck lesions tend not to show abundant calcified matrix. So even though it can be seen as this basophilic material, it sometimes needs to be searched for quite diligently. ERG and D240 will be positive, as well as SATB2 and the somatostatin receptors. And obviously, as already suggested, the fibroblastic growth factor 23 can be detected in these tumors as well. So here you will notice such a lesion affecting the bone, and in fact is destroying into it and into the associated sinus. The neoplastic cells are quite unremarkable, just spindle cells set in a background matrix material. Here you can see the much more characteristic calcification, as well as this grungy flocculent type material seen within the stromal compartment. Here is a much better area of that granular basophilic material. In fact, it's seen here adjacent to giant cells that can be seen at the advancing edge of these lesions as well. Here is another example with that myoid phenotype with very dense, thick-walled vessels. And of course, you will notice the adipocytes easily identified. The spindle cells tend to be somewhat bland, and they can range in cellularity from being a bit more hypercellular, as shown here, in comparison to some of the more hypocellular areas shown previously. This is a nice example of the CISH technique, identifying the fibroblastic growth factor 23 as a messenger RNA product, and is a very strong presentation. Extraskeletal myxoid chondrosarcoma. Well, as you know, it's got nothing to do with chondrosarcoma. And so it's a bit of a misnomer as a lesion, but still we kept the name just because it is still well inculcated into the literature. But it is an uncertain differentiation showing a multilobular architecture, abundant myxoid matrix, uniform cells often in this cord or clustered or reticular network, and of course associated with an NR4A3 gene rearrangement in the vast majority of cases, either with EWSR1 or TAF15. Most of the sites within the ENT area are the orbit, but of course intracranial and sinonasal tract can also be seen, and I've seen several actually in the oral cavity. So it has a multinodular appearance with fibrovascular septa, hypocellular lobules with abundant pale blue myxoid to chondromyxoid type matrix, although hyaline cartilage is not seen by definition. There's often a very hypovascular presentation to the stroma. The cords or small clusters, reticulated arrangement is quite characteristic for the tumor, with modest amounts of cytoplasm surrounding around irregular nuclei, and of course these delicate cytoplasmic extensions that go out into the stroma. Unfortunately, the immunohistochemistry is quite non-specific with a plus or minus either S100 protein, CD117, sometimes even synaptophysin or NSE, and then of course negative for GFAP and muscle markers. So it is a very challenging diagnosis to reach in many instances. So here is an example where you can see it's involving the skeletal muscle and expanding around a bone in this macroscopic representation of the multinodularity that can be seen. Here on low power, I think you can see the fibrous connective tissue septa as they divided out into these lobules or nodules of tumor, and the myxoid stromal component is very easily identified. Here you can see on slightly higher power that there's a very myxoid appearance to it with a reticulated appearance and kind of these anastomosing cords of the neoplastic cells. Again, you can tell how this is quite similar to what one sees with several other tumors, such as a myoepithelial type neoplasm, or perhaps others within the head and neck space. The background matrix material gives you this very myxoid overall appearance, kind of suspending the neoplastic cells within it. And so you can tell how some of the differential diagnosis, such as something like a pleomorphic adenoma even, would be incorporated into the differential. The EWSR1 break apart obviously is not telling you what the fusion partner is, but certainly can let you know that it is associated with the EWSR1 gene. The Gli-altered soft tissue tumor category, or Gli1 altered specifically, is a mesenchymal neoplasm, again of uncertain histogenesis, kind of thought maybe to be of perivascular distribution or parasitic distribution, but it is defined by the Gli1 alteration. So initially fusions were described in about 2/3 of the patients, but then amplifications have also been described, sometimes with co-amplification of some of the adjacent and neighboring genes. So about 40% of them occur in the head and neck, with the tongue most commonly affected site within that geographic region. Histologically, there's often a protrusion into the adjacent vessels with a wide spectrum of both architectural as well as cytologic features, ranging from nests and sheets to fascicles and pseudorosettes, cords, or even reticular pattern. Small to medium cells, epithelioid to ovoid, or spindled shape to them with a variable amount of cytoplasm. However, they do tend to be somewhat monotonous one to another. So it's a monomorphic population of cells, often having these small pinpoint nucleoli. Usually mitotic activity can be seen, but it is limited. There's usually a prominent vascularity. And of course, the stroma can range from myxoid to hyalinized. Now, unfortunately, again, the immunophenotype for this is quite variable. And you can see that I've put down things like smooth muscle actin, S100, CD10, CD56, and even CD99. So there is some overlap with a variety of other tumors that can occur in this location. However, they are usually negative with SOX10, HMB45, GFAP, CD34, and P63, as well as the neuroendocrine type markers. Interestingly enough, overexpression of CDK4, MDM2, and even STAT6 have been described in this tumor as well. So here you can see an example of the neoplastic cells as they have gone into a vessel, in fact, associated with some fibrin as part of a clot formation here. Isolated mitotic figures. Here you can see a mitotic figure there and another one out over here, so they certainly can be seen, but I think you can tell that there is an overall monotony to the neoplastic proliferation. Here is that rich vascularity that I was describing previously with extravasated erythrocytes and a very monotonous overall population. Sometimes a more nested architecture can be seen with a little bit more even chromatin distribution, and yet this is still very characteristic of the neoplastic proliferation. Another area here, just to highlight the rich vascularity and kind of a nested architectural appearance. So as I already mentioned, you can have amplification of GLI1, or you may have a rearrangement of GLI1 as identified by this particular fish break apart, but just be aware that you may have to do multiple different techniques in order to be able to document what is going on with this tumor. I will say this is also one of the tumors in the soft tissue section that does, of course, require a genetic alteration in order to be able to reach the interpretation correctly. The adamantinoma-like Ewing sarcoma category, as you know, is part of the primitive small round cell sarcoma that's defined by a variety of different members of the FET or ETS gene families, with the majority of these occurring within the first 4 decades of life. And of course, for the adamantinoma-like subtype specifically, very frequently identified within the head and neck area, salivary glands, thyroid, and even sinonasal tract. So it has this lobular architectural arrangement, sometimes a little bit of peripheral palisading, myxoid and even hyalinized stroma, and areas of squamous differentiation can certainly be seen in this tumor as well, although it is not a requirement for the diagnosis. As you would expect for a Ewing sarcoma, CD99 in a membranous type reactivity pattern should be seen, with positivity with NKX 2.2 as well. Now, specifically, depending upon which fusion partner is identified, FLY1 or ERG may be identified as an immunohistochemical finding as well. Now, because it's the adamantinoma-like Ewing sarcoma, CK-pan and either P40 and or P63 will be seen, although the CK-pan and P40 are by far and away the most helpful findings in this tumor. So here you will notice an example, very small blue round cell category, tumor necrosis easily identified, kind of a granular to coarse nuclear chromatin distribution, multiple chromocenters present with a prominent nucleolus and even mitotic figures. Areas of degeneration or apoptotic change can be seen in this tumor as well, making it sometimes a challenge for that small blue round cell tumor category. Sometimes there's a nice fibrous connective tissue stroma that creates a packeted appearance, as you can see in this example. Now, I've put up an immunoprofile here just to highlight that there are a number of lesions that can be seen within the small blue round cell tumor category within the head and neck. And this is just to show you that the Ewing sarcoma is going to have morphologic and immunophenotypic overlap with several of the other tumors that develop in this anatomic site, but specifically the NKX 2.2, CD99, and that co-expression of P40 with those markers is very helpful in reaching this particular interpretation. Here you will see a very strong reaction in all of the neoplastic nuclei with P40, highlighting the epithelial or adamantinoma-like appearance of the tumor, while P63 can also be seen, along with even CK56, since I've already mentioned there may be overt squamous differentiation in some of these tumors. CD99 must give you a strong membranous type reactivity. Of course, there can be co-expression in the cytoplasm, but it really is a membranous reactivity pattern that is the most sensitive and specific for those within the Ewing sarcoma family. And then NKX 2.2 is a strong nuclear reaction in almost all of the neoplastic cells, as you can see here. And let me just say that the NKX 2.2, in looking at gene expression profiling, is the downstream target of EWSR1 FLY1 fusion, and therefore it is required for oncogenic transformation in order to become this particular tumor. Let's now transition into the hematolymphoid proliferations and neoplasms. You will notice that 35 different entities were incorporated in 2005, 16 in 2017, and now a slight bump up in the 22 edition, specifically to 22 diagnoses. And again, this is quite specific. Instead of for some of the site-specific lesions, all of the hematolymphoid lesions have been aggregated into a single group. So you will notice the new entities. There are only 3 of them: EBV mucocutaneous associated ulcer, IgG4 related disease, large cell B-cell lymphoma with IRF4 rearrangement, juvenile xanthogranuloma, and Erdheim-Chester. So let's talk about some of these lesions. So first of all, as the EBV positive mucocutaneous ulcer, this is a very specific finding that is a self-limited lymphoproliferative disorder, but it has these remarkably polymorphous lymphoid infiltrate with Hodgkin-like cells that are seen in the deep portions of the lesion that can be seen usually in immunocompromised patients. So the immunocompromised can be elderly or autoimmune, obviously iatrogenic related things, and HIV and post-transplant setting as well. Usually a well-circumscribed ulcer. The base has this polymorphous infiltrate with a number of different lymphoid cells present within it, including immunoblasts and plasma cells, and then these large Hodgkin-like cells present in the base. Vascular destruction and thrombosis is usually quite prominent, and so you get a fairly large amount of necrosis. And of course, the neoplastic cells are going to show a mixed population of B and T cell markers, while EBER must be documented within it as well. Sometimes even CD30 and rarely CD15 can be co-expressed in this tumor or tumor-like lesion. IgG4. So this is, as you know, a systemic immune-mediated but mass-forming lesion. And it's because of that mass-forming lesion and the association specifically in the submandibular gland and orbit that it has been incorporated in this chapter as well. It is by definition an IgG4-rich lymphocytic infiltrate, storiform fibrosis, obliterative phlebitis, and of course a typically elevated serum IgG4 level can be seen as well. So the combination of those findings, obliterative phlebitis, storiform fibrosis, and the lymphoplasmacytic infiltrate with an increase of IgG4 positive cells is quite specific for the diagnosis, although there are other entities that can overlap it. And even things like an inflammatory myofibroblastic tumor, multicentric Castleman's disease, Rosai-Dorfman, et cetera, can have IgG4 positive cells. And therefore, this is something that must be thought about and excluded actively. There are also some clinically compatible features. These are related to having IgG4 related diseases in other anatomic sites, having the elevation in the serum of IgG4, and of course, if there's any sort of response to steroid treatment and or rituximab, this should certainly help to confirm the overall diagnosis. So the tables that are present within the book, I've only limited this one to the head and neck areas, but just be aware that especially in the hematolymphoid book, they have the criteria for each anatomic site specifically documented. The old nomenclature or obsolete terminology is highlighted here in the parentheses. So things like Kuttner tumor and chronic sclerosing sialadenitis should no longer be used for the IgG4 related diseases. As you can tell, there are a number of different salient clinical features that need to be seen as well in making this particular interpretation. So I think you can see that there is clearly a chronic inflammatory infiltrate present here, as well as a storiform fibrosis. There is a greatly increased amount of lymphocytes as well as plasma cells, actually destroying the background salivary gland parenchyma in this location. It can also be seen in the sinonasal tract. Here's an example of that lymphoid population and plasma cell population with a storiform fibrosis present just below the sinonasal tract mucosa. Areas of phlebitis, as highlighted by the arrow here, are diagnostic when they are seen, but just be aware that they are often quite difficult to be able to highlight. Here you can see a very rich plasma cell population, which is of course going to be tested for IgG and IgG4. And here you will notice there is a large number of IgG positive cells, but likewise a similar number of IgG4. And so the ratio here is greater than 40%, helping to reach a determination of the diagnosis in this example. The large B-cell lymphoma with IRF4 rearrangement is not something I've ever made a diagnosis of. I will tell you that right now. I am not a hematopathologist, but because it is something that occurs almost exclusively within the Waldeye's ring as its most common presentation, and also in the pediatric age group most usually, we thought it should be included in the book as well. Usually it has either centroblastic morphology, intermediate size with blastoid morphology can also be seen, ranging from either a follicular and diffuse, or diffuse growth pattern with positivity with CD20, CD79A, and PAX3, while BCL6, IRF4, and MUM1 are also seen in this lesion. Sort of by definition, IRF4 should be seen by FISH rearrangement as well, with an absence of either BCL2 or MYC gene rearrangements. So here you can see a kind of a diffuse pattern in the lower portion of the field, a little bit more follicular architecture here, with a very blastic appearance to the neoplastic cells and very high proliferation index, while here I'm just highlighting two of the immunophenotypic patterns of BCL6 and MUM1, but just be aware that this is a very specific tumor entity category for the new book. Juvenile xanthogranuloma, clonal infiltrate of non-Langerhans cell histiocytes, showing a favorable outcome for most, except there is some rare association with systemic disease. The skin of the head and neck is most commonly affected, and young patients are the most usual patient-affected group. The histiocytes are intermixed with these fabulous two-ton giant cells that you can see in the upper panel, very characteristic for the lesion, showing positivity with either CD68 or CD163, while they should be negative for Langerhans cell markers such as CD1A or CD207, which is Langerhans. Let's now talk about Erdheim-Chester just for a moment to recognize that this is an example of the systemic histiocytic neoplastic condition that involves multiple different organs of mature histiocytes in a background of fibrosis. So when it occurs within the head and neck, it most frequently presents with these xanthelasma-like lesions around the eyes, face, and neck with a slight male predominance, and sometimes will even show areas of sclerosis in facial sinus imaging studies. It is not uncommon to have an underlying clonal hematopoietic lesion or even an overt myeloid neoplasm such as CMML as the most frequently identified. So as you would expect, they're going to be collections of histiocytes, very bland overall cytologic appearance with foamy and eosinophilic cytoplasm. And again, they will be reactive with CD163 and CD68, but negative with Langerhans type markers. So just so you know that even though it is a diagnosis, when you think about the number of times we make a xanthelasma type diagnosis, it is really something that has a remarkably wide distribution across the body. So you can see here are the number of sites and how commonly they are affected, what the various presentations may be, and what are the findings for these entities. So it is something that is a multi-system disease as its presentation. Further, you will notice that there are many different mutations identified in this lesion. While most commonly BRAF mutations with V600E specifically is seen in the majority, there are a number of others that can be seen as well in this multifocal disorder. An example of just the histiocytes, you can tell there's lots of foamy cytoplasm present within it, immediately below the respiratory epithelium here, with a multitude of histiocytes. And of course, they would be reactive, as I already mentioned, with CD163. That brings me to the end of this particular presentation, and I hope that you have enjoyed our exposure to the new 2022 5th edition of the classification of head and neck tumors. I'll be more than happy to take any questions that you may have at this time, and hope you have a fantastic day.
Okay, so 佢而家唔喺度嘛？係要叫翻佢，我要入翻去先，我要翻 backstage 先。
Okay, I think I've done that. Although I don't know, but
Yes, you are,
okay.
but we don't have your image somehow. 而家廣播緊㗎啦，係咪啊 ？Okay, 開咗係咪？聽到。Ladies and gentlemen, now we have Dr. Lester Thompson with us, but for some reason he is not appearing with. He's here definitely spiritually.
So Dr. C, I can see that it says in the top, it says host has stopped your video. So
okay.
I don't know why that's the case, but
okay,
that's okay. I'm here.
We beam you back, Lester. Okay, so we have compiled the questions that I've collected. We've collected from the audience. Oh, this one, no. 係咪呢個？係呢個係咪？ Okay, so the first one I don't think Lester would be interested. What's the difference?
No, I'm happy to try and say something about that, and that is anytime you have a tumor or a lesion that is being defined by its molecular rearrangement, and specifically that is part of the name of the lesion, there isn't really much that you can say then about the histomorphologic findings in that particular tumor. You know, in this case, if you think about, you know, this particular tumor category, and I've never made this diagnosis, I am not a hematopathologist, but if I look at this and say, okay, it can be either follicular, it can be follicular or diffuse, or it could be just diffuse, and most cases show this particular rearrangement with strong expression of IRF4 immunophenotypically. So if you did the immuno, then you're going to be able to detect that particular lesion, at least suggested, and then do the molecular study. So unfortunately, I don't think that just looking at the morphology alone, you can be definitive about these particular entities.
Thank you. Very nice.
I'm sure Dr. Chen is listening to me, and John would just flip out because he maybe can do it, but I cannot.
No, we muted him if he's here. All right. Okay. Next one. This one, BRAF B600E mutation IHC or genetic tests for ameloblastoma?
So I do not. You know, I think this particular finding is unique as far as the molecular alteration for this tumor. But, and it's not really unique, obviously, as you know, BRAF is seen in, you know, just a myriad of different tumors now. But, you know, for me, this is a standard H&E type diagnosis. No matter which subtype you may see of them, they all have a very characteristic histologic appearance. The probably one exception to that is if you think about the unicystic ameloblastoma, the reverse polarization, the subnuclear vacuolization, all of that sort of feature is so subtle and very, very delicate in its presentation. And because it's just, you know, kind of 2 or 3 cells thick as it's lining that particular cystic space, it can be very, very difficult to get a unicystic ameloblastoma as the diagnosis. And so perhaps doing the immunohistochemistry for that lesion may be of some value. But I must say, I do not use it routinely in my day-to-day practice. There have been some who have suggested that in ameloblastic carcinoma, that may be of some utility, because if you think about a lesion, especially involving the jaw, and you're trying to understand, is it a mucosal-based lesion that is invading into bone, or is it primarily centered within the bone and growing out into the soft tissues of the jaw? the management may be slightly different for those lesions as an ameloblastic carcinoma versus a squamous cell carcinoma as an example, because if you think about the acanthomatous appearance of the stellate reticulum, it can be quite morphologically identical.
Thank you. Thank you. So the answer is no. Okay, another molecular test. Can rhabdomyosarcoma with TFCP2 RAMS rearrangement positive for EWSR1 fish? And how do we differentiate this from the Ewing's family tumor?
So I think from a strictly morphologic standpoint, and I do think this has a very nice morphologic correlation to it, because it's kind of an ovoid to spindle cell neoplastic population. You may have some areas that have a little bit more rhabdoid type appearance to it, but that spindle cell morphology is not really something that you see in the traditional Ewing category, especially within the head and neck space. The Ewing family obviously has expanded greatly in the soft tissue area. And so, you know, there may be some spindle cell tumor categories truly in bone and soft tissue anatomic sites rather than in the head and neck. But I think within this space, the presence of both an epithelial marker, presence also with MyoD1 especially, and then of course the co-expression of ALK is something that is really quite unique in this particular tumor entity. And I'll say the cases that I have seen, and so far, well, how many have I seen? Who knows? Because, you know, we didn't make this diagnosis 5 years ago. So if I take it back in context of the diagnoses that I've made at this particular point, the idea that they look like spindle squamous cell carcinomas of the oral cavity, and one of the major triggers to think of this particular diagnosis is actually the fact that it is occurring in a younger end patient. In other words, someone who has a spindle squamous cell carcinoma of, quote, the jaw, and they're 25, you know, this is a very uncommon presentation. And so that's really the trigger to say, whoa, you know, is this really a spindle squame, or could it represent some other lesion in the differential diagnosis?
Thank you. I'm not sure why this question is here. I'm not.
No, this is fantastic, because I'm just going to be thrown under the bus by all of my people as some old fool that doesn't know what they're doing. And that's okay. I find that the use of molecular testing in day-to-day practice is actually remarkably uncommon for me. However, let's say that I have a core needle biopsy of a salivary gland tumor in someone who is not going to be a surgical candidate, and I'm trying to separate between a hyalinizing clear cell carcinoma and a clear cell mucoepidermoid, where the outcome of those patients is going to be quite different. In that particular setting, I would do the molecular testing, and I would do it sequentially based on which histologic feature was driving the interpretation. So if I really thought in my heart of hearts, oh, you know, this is going to be a mucoep, I'll do the mammal too. If I thought, oh, this is really a hyalinizing clear cell, then I would do the EWSR1. So if I look at that, and I know that it's going to have clinical management implications for the patient in what's going to happen next, then I would definitely do that particular study. If I think about the small blue round cell tumor category in the head and neck, and knowing that if I'm able to identify IDH2, they're going to actually have a targeted therapy for that particular patient who may have a, you know, sinonasal undifferentiated carcinoma category, then I would do that particular molecular workup for that person. But if I have just a standard H&E that looks like mucoepidermoid carcinoma, I am not going to do a mammal 2 to confirm it, because it's not going to make a difference to the management. And most of these patients do not have metastatic disease at the time of diagnosis. And it's also not going to change the management of that particular patient, because there's no targeted therapy against it at this point. So you have to kind of use a logical approach of, why am I doing the molecular study? In this particular case, is it going to alter that particular patient's long-term outcome or management?
Thank you. That's a very sensible thing. But I think nowadays a lot of practicing pathologists are very excited about molecular tests, and they tend to.
I know that there are several practices here in the US that almost uniformly will perform a FISH study of some sort on every single tumor. I mean, they have a pleomorphic adenoma and they will do a FISH study for PLAG1 or HMGA2. They'll just do it as part of their management approach. I'm not there.
But for you, it's different because you make up the entities and everybody follows.
So well, I'm not making them up. I may just be giving a name to things we recognize.
Okay, this is a more down to earth question. Without clinical information such as phosphate wasting or osteomalacia, are there any histological hints that alert us of the diagnosis of phosphaturic mesenchymal tumor?
You know, I think the sort of granular blue grunge that you see in this particular lesion is definitely the most helpful finding. You know, if I can use a morphologic correlate with the previous, you know, Wegener's granulomatosis or polyangiitis with granulomatosis, as is the correct term now. When I think about that particular disorder, it has a very characteristic blue granular degenerative karyorrhexis to it. And that same phenomenon is what you see in the phosphaturic mesenchymal tumors. Now, unfortunately, it's definitely not in every field. So depending upon the biopsy, the size of the biopsy, or, you know, what has been taken out, can give you some difficulty in determining what's going on. With the head and neck lesions specifically, though, it's been my experience that they will often have a myeloid phenotype to them, where they have a very rich myeloid appearance, whether it's related to a perivascular thickening of all of the vessels or just a myeloid type proliferation. And then, of course, the ones in the head and neck also tend to have a much greater association with adipocytes. So in other words, you'll see a lot of adipocytic tissue present within it. And so that can be more of a hint than when you see that same tumor category in other anatomic sites. And I will also say in the head and neck lesions, true calcification, you know, the actual, you know, block-like calcification that you see in other anatomic sites is not usually seen either. So it's much more of this very fine granular material that gives you the hint to the diagnosis for them, at least, you know, for the ones that I have seen.
Thank you. Okay. Smooth muscle tumor. In the presence of smooth muscle tumor, when will you perform EBA?
You know, I mean, this is obviously a very loaded question, right? Because the implication here is, are you practicing in a vacuum? And you should not be, right? So I don't know if you guys have listened to all of the presentations this evening, because obviously there were several of them. But when I was doing the one specifically around odontogenic tumors, I basically said, if you don't have a radiology, you shouldn't diagnose any of the odontogenic lesions, because it's a radiology, pathology, and many times also clinical correlation of those findings in order to be able to get to the diagnosis. If you think about fibrous dysplasia and trying to separate it from ossifying fibroma, this can be exceptionally difficult if you don't have a radiograph to look at. And so if I'm looking at a smooth muscle tumor, the first thing that I do is I go to the clinical history and try to figure out, you know, what's going on with the patient. Where is the lesion located? Is it in an unusual anatomic site? And for the most part, the EBV-associated tumors, the vast majority of them are actually in the larynx, pharynx, or hypopharynx area. Very infrequently are they in the oral cavity or sinonasal tract. So if I have a smooth muscle tumor affecting the larynx, I'm for sure going to find out, is this person a transplant patient? Do they have some sort of immunocompromise? Do they have a genetic tumor syndrome? Do they have some sort of, you know, inherited disease that may be giving them this particular finding? So aside from that clinical information, which I do think as pathologists, we're part of the clinical management team. We are not a separate group that just functions in a silo. we are part of that clinical management team. It's a multidisciplinary approach, and you need to take your responsibility to go and look at what the clinicians already have looked up and tried to give you. Even though they may not put it on the requisition, it's generally still somewhere in the chart. So having said that, I do think that the EBV-associated smooth muscle tumors often have a very small blue round cell appearance to them rather than being the characteristic fascicles or elongated spindle cells. So they have a much more rounded morphology to them. And I think that is one of the tip-offs to what you're dealing with. It's usually much, much more cellular, but very limited in the way of mitotic activity and also limited in the way of pleomorphism. So ironically, you look at it and you think, wow, this is supracellular. And then you go and look at high power and you say, they're all kind of the same. They're very similar one to another. There isn't much in the way of any sort of variation. And there's no mitotic activity and there's usually no necrosis. And you think, okay, so this is maybe a small blue round cell tumor, and then it should click, I also need to think about the EBV-associated smooth muscle tumors, and that can be one of the tip-offs to doing it. So I do not routinely perform EBER on all smooth muscle tumors, but I certainly will perform it if it is in an unusual anatomic site, such as the larynx, hypopharynx, or pharyngeal area.
Thank you. Coming back to phosphateric mesenchymal tumor, how is the differential diagnosis between this and osteosarcoma?
So, just as I said a couple of moments ago, the idea of that myoid phenotype and the presence of fatty tissue within it as part of the underlying neoplastic condition, that is not something that you ever really see to any sort of, reproducible area. If you think about it, in osteosarcoma, I mean, how often do you have heterologous elements in an osteosarcoma? You may have heterologous elements in other tumor categories, but usually not in osteosarcoma. And then I suppose, if you think about the fibroblastic growth factor that is the driver of the phosphateric mesenchymal tumor category, if you have that available doing the fibroblastic growth factor, specifically 23, if you did that, you would be able to have, a separation if you were relying on immunophenotypic expression. I'm not sure about the wide commercial availability of that particular antibody. So I sort of say that with a little bit of reticence because I'm just not sure how commercially available that is globally. I mean, do you have it, Gary? Do you know if it's available to you guys?
Which one?
The fibroblastic growth factor 23, FGF23? No, okay. Just the fact that you're rolling your eyes into the top of your head tells me no.
Sorry, I have to apologize for my ignorance.
No, it's okay. I'm sort of ignorant about it too. This is not something that, I do very regularly because I do think that granular grunge type calcification or degenerated calcific material is very, very helpful to the diagnosis. Okay.
Thank you. The next question is, what features can help to raise the suspicion of adamantinomatous-like Ewings so that to perform CD99 biopsies with squamous differentiation?
So actually it should be adamantinoma-like Ewing sarcoma, just for whoever raised the question. Otherwise, if you don't use the right nomenclature, you may get into trouble with other people. So actually, this is a very difficult thing if you have a very, very small or core needle biopsy, because sometimes that squamous differentiation can be quite remarkable. I do think, however, the basaloid phenotype that you see with this particular tumor is probably the tip-off to it. So in other words, it's a much more basaloid or very high nuclear to cytoplasmic ratio component to the neoplastic cells. Whereas when I think about most squamous cell carcinomas, you usually have quite a bit of cytoplasm surrounding them. There may be some variation, cell to cell, but for the most part, there is still more cytoplasm in true squamous cell carcinomas. The other thing that can be, really quite helpful is a comment that I'm going to make that applies to all of the fusion or rearrangement related tumor categories. So if I were to include, let's say, biphenotypic sinonasal sarcoma as an example, both of these tumor categories have a very monotonous appearance to the neoplastic cells. So if I look at an adamantinoma like Ewing's, it's not saying that the cells are not atypical. They are atypical, but when you look at them, they all look like they are replications of one another as you look at it. So it's a sheet-like distribution of cells that all look very similar to one another. Whereas when I think of squamous cell carcinoma, there's much more pleomorphism and variability cell to cell. One is huge and monstrous and has 5 nuclei in it, and the next one is super small and has a very high NC ratio and, a pycnotic nucleus and no. Whereas when you look at adamantinoma, that fits into the same idea of having overt squamous differentiation. And when you have that areas of squamous differentiation in a tumor that otherwise has a very remarkable monotony to it, that's when I think about, what are some of the other tumor categories that I need to consider? And, I think in this particular presentation, I did include a very nice table of the small blue round cell tumor category and how many immunos you need to do in order to be able to highlight that particular finding. And part of the reason for that is because there is a lot of morphologic overlap between these lesions. And if you don't do a spectrum of immunophenotypic studies, you're just going to be lost. And so doing a keratin, doing the P40 synaptophysin, INI1, doing the CD99, SOX10, etc. If you don't do those markers, you're not going to be able to find it. I mean, I suppose I could go back to the original question just a few moments ago about the TFCP2 rearranged rhabdo. If you only did a pancytokeratin to prove squamous cell carcinoma as a spindle cell variant, it would be strong and diffuse. You'd write the diagnosis and go home. So it's only in the utilization of a panel approach with a variety of different markers included that you're actually able to reach these somewhat less common but still very differently managed neoplastic proliferations.
Okay, thank you. I know time's up, but are you game for 1 or 2 more questions?
Oh, sure.
Thank you.
Are they cocktails? Oh, no, it's the middle of your day, so you can't have cocktails yet.
Why not? Today is Saturday. Okay, what's the reliable way to differentiate between clear cell variant of COT, which lack calcifications, negative amyloid, against the clear cell odontogenic carcinoma?
The cytologic pleomorphism, tumor necrosis, and increased mitotic figures are really going to be the only histologic criteria that would lean you towards odontogenic carcinoma. I don't think that you can rely on any of the other characteristics because they can be overlapped between those 2 lesions.
Okay, thank you. Let's see, one more question. Okay, this one. Do you have experience with cases where a patient has a known history of olfactory neuroblastoma, presenting with metastatic tumor, which is positive for neuroendocrine markers, negative for cytokeratin, but no substentacular cells? So what's happening?
Yes. So this is a good question, and that is actually saying, are the substentacular cell component part of the neoplasm and therefore present in the metastatic foci? And they are in many instances, but they are not always present. I will say that the substentacular cells, we used to just say S100, but over the last several years, GFAP is positive in the substentacular cells, and more importantly, SOX10 as a nuclear reaction is positive. And so when you think about substentacular cells in a lymph node, S100 is super difficult to interpret in that particular setting because, you can have all sorts of other cells in the background lymph node that can cause confusion. But if you're doing a SOX10, it very nicely highlights those individual cells. Now you have to use a little bit of your imagination to say, yes, there is actually a sustentacular distribution of them, because it's just the nucleus that's being identified. You don't really get the hint of the circular nature or the alveolar appearance to that. So I do think that other markers can be used in order to highlight those sustentacular cells. So don't necessarily give up on the tumor and say, oh, I must have a new tumor category. It's not an olfactory neuroblastoma. It's a metastatic neuroendocrine tumor of some other type, because obviously the olfactory neuroblastoma does not have keratin expression to any great extent at all. I know this is a major point of contention with a lot of people. How much can you accept? How much is focal? How much is not there? But I do think that, you know, as we expand this particular category more over time, I do think that some of the molecular findings within this group are probably going to help to be able to separate out, especially between the high-grade lesions that may have overlapping histology and immunohistochemistry between epithelial and neuroendocrine type markers.
Okay, thank you very much. Very detailed and illustrative, a comprehensive solution to this question.
Well, it's a bit long, right?
I think you've cleared all the questions, and amazingly, we're only 5 minutes overrunning. Okay, so I get there are no more questions. I think we've done all, and so I would like to thank you, Lester, for joining us, giving the really very interesting lectures, very timely updates, and very interesting approach to various questions and difficult scenarios that our audience has. So,
well, can I just end on the fact that still remember that almost all of your practice is still horses rather than zebras. We have presented a lot of zebras this evening between all of us. And, you know, it is always interesting to think, oh, that's what I have. But, you know, I think for the most part, when you come across your day-to-day operations, they still fit into the 90% of tumors in the head and neck or squamous cell carcinoma.
Thank you for this advice. Now I'm very relieved. So I know 99% of the time I'll be correct if I just write down SCC, correct?
As long as you're not in the salivary gland, yes. Thanks very much. Have a fantastic day.
Thank you very much, Lester. And I would like to thank all the audience for supporting the Hong Kong IAP and the Asia Assembly of the Asia Pacific IAP for these WHO series. So stay tuned. We will have more coming up end of this year and also next year. Thank you very much and have a good day, good evening, and good luck. Thank you. Thanks, Lester. Bye.
Okay. Thanks, Gary. I assume you don't need anything else from me at this particular point, right?
I'll email to you.
If there is.
Oh, I do need something from you. I'll email to you.
Okay.
Okay, have fun for tomorrow's meeting. Thank you. 我等佢走啦。我點樣刪 meeting？